So we are live on YouTube now.
Okay. Uh, Good afternoon, everybody. I welcome you all. I, Dr. Rasik Shah, Senior Pediatric Surgeon, welcome you all for today's masterclass on behalf of SRCC Children's Hospital managed by Narayana Health. As you know, we are in pandemic of COVID-19, but most of the hospitals, or at least in SRCC, we are almost back to normal. Our operating rooms are functioning almost to the maximum capacity. Uh, and many of you have visited SRCC Children's Hospital, and it is very spacious. So we have between the beds uh, uh, adequate space, and so whatever we say, social or physical distancing is always there. Today's master class was supposed to be started by Dr. Akhil Tawari, and he was supposed to speak on approach on management of the spinal deformity in children, but he is not able to make it. And instead of him, I will be speaking on surgical vomiting in children. Now, some of you have already attended this talk, so it may be repetition for you, but many of you may not have attended, and we can discuss about that. This was the talk which was ready with me. I have many talks ready, but not for the family physician. So I decided to repeat it. And along with me, we have Dr. Bharat Parmar. He is a senior pediatrician who is going to tell us about how to calculate doses of the medicine in a simplified way. And the third speaker is Dr. Sneha Shah. She is oculoplastic or eye surgeon, and she is going to tell us uh, uh, tears, about tears, details of that. If there is excessive tears, how to diagnose and manage the same thing. With me, we have moderator Dr. Avisha and Dr. Pooja Mehta. Are they joined? Avi, Pooja? Anyway, what we'll do, we'll start with my talk. So I will start with share screen and start my talk. Can you see my screen and audio is clear? Hello, anybody can reply?
I can see you.
You can see and you can hear also. I mean,
Yeah. Yeah.
okay, fine, thank you. So surgical vomiting in children,
Yeah. Screen also seen.
yeah. So how will you differentiate between regurgitation and vomiting? So regurgitation is effortless return of food from stomach, and there is no associated nausea and retching. Vomiting is forceful expulsion of gastric or intestinal contents and often associated with nausea and vomiting. Now, etiology, if we have to go through the causes of vomiting in children, we can divide that into surgical cause and medical causes. Surgical cause is gastroesophageal reflux disease. Now, there is a physiological part of GER, which we will not call as a surgical cause. We will we will discuss about this when you call it as a GERD and pathological or surgical cause. Apart from that, we have achalasia cardia, congenital esophageal stenosis, and congenital esophageal stenosis is a condition in which there is at the junction of upper two-third and lower one-third of the esophagus, there is narrowing since birth, often associated, there is a cartilage there, and the treatment of that is basically resection of that area and anastomosis. That can be done open or that can be done even thoracoscopically. Then there is a condition known as hypertrophic pyloric stenosis, uh, gastric paresis, small bowel obstruction because of anything, but the common causes in children will include malrotation of bowel, duodenal stenosis and annual pancreas, superior mesenteric artery syndrome, distal small bowel obstruction because of any cause, large bowel obstruction, the common cause would be Hirschsprung's disease. So these are all surgical causes and we will go through some of them. We may not be able to complete all, but we will discuss about common conditions and uh, common conditions we will discuss. Sorry. Okay, 1 minute. So medical causes will include eosinophilic esophagitis, gastritis, gastroparesis, cyclical vomiting syndrome, abdominal migraine. Now, all these conditions are not easy to diagnose, and generally, we will have to take help of pediatricians or gastroenterologists. The non-gastrointestinal causes also can cause vomiting, and it can be because of the raised intracranial tension, either because of SOL, space occupying lesion, or maybe because of infection, chronic sinusitis, uremia, overfeeding, then mitochondrial cytopathy, then DKA means diabetic ketoacidosis. Recently, we had a child, 12-year-old girl, who came with abdominal pain and on investigation was found to have diabetic ketoacidosis. Addison's disease we see quite often. Acute hydronephrosis due to PUJ obstruction, which we call as a detal crisis. So all these are non-gastrointestinal causes of abdominal pain, and they can fool many times all of us. So we need to remember, apart from medical causes, medical GI causes, surgical GI causes, there can be causes from the other systems also. Now we will discuss some of the cases which along with that, we will discuss about the condition. Now, if this is we are going to discuss one 3-month-old child whose birth weight was 2.7 kilo and the weight at the presentation was 3.5 kilo and had history of non-bilious regurgitation after feeding. The child also was irritable. There was arching, choking, gagging, feeding aversion. There was history of 2 admissions to the hospital due to pneumonia. Now, if you see over here, the child is arcing, and this is a classical sign of a GER, gastroesophageal reflux, and the syndrome which is known as Sandy-First syndrome. So clinically, this child has GER. So what next we'll do? We will order barium meal, and here you can see there is a reflux of gastric content into the lower esophagus, and it is going right to upper esophagus. And we do barium to rule out any other cause of vomiting, meaning if there is achalasia cardia, you can pick it up. If there is a obstruction at the pylorus or any other cause, you can pick up with the help of barium. Sorry about that. So we can rule out any other cause. Often you may not be able to see GERD while doing barium. So it is diagnosis of exclusion also. If there are no other cause, we will say it is probably because of GER. Now we have picked up the GER in this particular child. So what next we should do? So we should start medical line of management, and what all the principles of management includes: to relieve the symptoms of vomiting. Lot of them will have esophagitis. They will keep on crying. So you want to relieve the symptoms. So you want to decrease the pain of esophagitis. Then you want to heal the esophagitis, and manage and prevent the complication which will arise because of the esophagitis, which includes formation of the stricture, and if not treated well, in long run it can even give rise to cancer, especially in adults. We don't see that in the children. And once the esophagitis has healed, the symptoms are relieved, you want to maintain the remission. And what all we will do to do this? We will start on thickened, frequent feeds, upright position, or a sitting chair. Then you can give loose clothes and diaper. If there is a tight clothes, again, they are likely to have more symptoms related to GER. Then you will start prokinetics like domperidone, perinom, or cisapride. Then you can add antacids like mucin gel, which can give rise to less esophageal pain. We can start H2 blockers, PPI. Now, if the symptoms are mild, we will like to start with H2 blockers. But if the symptoms are very severe, then only we will give PPI. And in an older child, you will tell them to take less spicy and oily food and no smoking. Now, what are the complications which are related to GERD? As I told you, there is a reflux esophagitis which will give rise to chest pain. If not treated, it can give rise to stricture, Barrett's esophagus. Barrett's esophagus is a shortening of the esophagus, and ultimately all this condition can lead to adenocarcinoma. Then there is definite association of reflux, cough, laryngitis, asthma, and even dental erosion. And typically, the cough and asthma is at the night time when the person is sleeping. In a sleeping position, the reflux is more likely to happen. So, if anyone is having cough at night, always the possibility of reflux esophagitis should be kept in mind, and it should be taken care of. Then excessive regurgitation will cause feeding refusal, anorexia. There will be unexplained crying in a small baby. If they are crying, then always uh, remember the possibility of reflux esophagitis. If there is a definite aspiration, they can have choking, gagging, and coughing. There can be sleep disturbances. It can also have abdominal pain. Now, some of these which are not definitely associated with reflux esophagitis, but it can be because of that. It includes bronchopulmonary problem like asthma, pulmonary fibrosis, bronchopulmonary dysplasia, laryngotracheal and pharyngeal problem like chronic cough, chronic laryngitis, hoarseness, pharyngitis. Even sinusitis can be because of that. In small babies, the apnea, bradycardia, and life-threatening events, all this can be because of the primary GERD. Now, Now, if barium does not show GER, then what one can do to prove there is a reflux is you can order milk scan. Uh, Now, what is the role of milk scan? So it is a definitely better diagnostic value, but it is not 100%. Only if it is aspiration, then one can pick up there is a presence of GER. Mild reflux may not be picked up on milk scan. Uh, so uh, it will demonstrate aspiration. It will show that there is a delayed gastric emptying. Sorry. It will not show the anatomy because we want to see the anatomy to rule out other causes of vomiting. Now, if medical treatment, how long you will like to continue and reason by which GR can be resolved. So the natural history of GR in infant is the infant grows, as infant grows, the lower esophageal sphincter matures. In infant, reflux becomes evident in the first few months of life. It peaks at around 4 months and resolves in up to 88% of the kids by 12 months, and then nearly in all by 24 months. The symptoms in older child tend to be chronic, and there is waxing and waning of symptoms, but complete resolve, it may resolve completely only in 50% of the patients. It does not resolve in all. So this is a natural history. So if we can manage the infant with medical line of management, then we may not need any surgical intervention. But some patient where there is a pathological problem, then we may end up with the surgery. Now, on treatment, if the child develops one more attack of LRTI, or if there are choking episode, or if there is a life-threatening event, then this patient should be subjected to surgery. So, what we do in surgery? We do fundoplication. We used to do this surgery using open technique. Today, we do it laparoscopically. What you are seeing on the video is in a 3-month-old child, we are doing fundoplication. The weight of the child is about 3 kilo. So what you can see here is a suture which has been taken to lift the liver up so that we have exposure of the esophagocardiac junction. So that is esophagus and that stomach, and we are working at the esophagocardiac junction. So that is esophagus. You can see beautifully. The vagus nerve has come into the view. That is the vagus nerve, posterior vagus nerve. That is esophagus, posterior vagus nerve, and this is stomach. This is the liver, and that's the diaphragm. So what we are going to do, laparoscopic fundoplication. Again, you can see beautifully vagus nerve posteriorly. The magnification of laparoscopy is multiple times, like 20 times, so that you can have beautiful view. So any surgery which you want to do at high test, the best way is doing it laparoscopically. The exposure, we will not get the same exposure even in open surgery. So this is what we are doing is suturing of the crura. So that is left crus of diaphragm and this is right crus of diaphragm. So we are narrowing that opening so that the stomach will not go up. And these are the 2-0 ethibond suture which we are putting to narrow the hiatus. And these are permanent sutures, and it is used by cardiac surgeon for the sternum closure. So these instruments are 3 millimeter, about 20 centimeter in length, beautifully designed, and you can carry out any kind of surgery in a small kids. Now we are pulling the stomach, fundus of the stomach behind the esophagus. That's esophagus. This is stomach on right side and left side of the esophagus. What we were doing was shoe shine sign, like if you are uh, yeah, so we were checking whether it is moving easily or not. What we are doing is taking a bite through the esophagus. We took on the left side esophagus and then the right side of the esophagus, and then we will approximate that suture. So what it does is it creates a high pressure zone on the lower esophageal area. So food which comes down into the stomach from esophagus, it will not go back. So we have to create a high pressure zone, and it should be floppy. So it should allow the food or milk to go down, but it should not allow to food to go back. So you can see small cuts, one at the umbilicus, and these are through 2-3 millimeter cuts on both sides. So with these 3 cuts, you can complete the procedure. There is the umbilical incision is generally not seen. So cosmetically is very good. And then post-operatively, the chances of adhesive obstruction are almost nil. In open surgery, the chances of adhesive obstruction over the lifetime is about 5 to 10%, and these children can be fed immediately after the surgery. Immediately meaning after 6 hours we can start feeding, and they can be discharged in 2 to 3 days. So these are the advantages of doing it laparoscopically. Now Another child, 6-year-old child, who came with the symptoms for 3 to 4 months of nausea, abdominal pain in epigastric region. There is definite regurgitation and vomiting. There is a chest pain uh, in a retrosternal area. There is some dysphagia. Pain used to worsen with spicy food. So with all this history, it is classically suggestive of presence of esophagitis, uh, uh, esophagitis due to GERD. So we will do the same investigations and confirm our diagnosis. And in addition to the same investigation, we can do something more also. But you can treat this child with antacids and H2 blocker, and with H2 blocker with symptomatic relief. Okay, this child was treated with antacids and H2 blocker with symptomatic relief, but there was no complete relief. So with treatment, it will go down. As soon as you stop treatment, they will come back with vomiting. So how will you manage this patient now? So the standard investigation will include barium meal, 24-hour pH study, and endoscopy with biopsy. We have already discussed about barium meal, so we will not go into details of that, but we will discuss about 24-hour pH study and endoscopy with biopsy. So 24-hour pH study we do. The advantages are what? If there is any uh, detects episodes of reflux, the 24 hours pH study, it determines the temporal association between acid GER and symptoms. It determines effectiveness of esophageal clearance mechanism, and it assesses the adequacy of whatever treatment we are giving. The limitation is it does not detect non-acid reflux. So whenever the pH is less than 4, it will detect. If pH is more than 4, it will not detect that there is a reflux. Now the indication is, as I told you, there is when the person is on the treatment, you can assess the efficacy of acid suppression during treatment, and you can evaluate if there are apneic episodes at night, if there is atypical presentation because of chronic cough, stridor or asthma, and if we don't know whether it is because of GER or it is something else, then if we do this test, we will come to know. And then the last investigation is endoscopy and biopsy. So if we do GI endoscopy, as you know, we have pediatric gastroenterologist at SRCC, and
जा
we have pediatric scopes also, and we can do. Uh,
चहा केलायस का बाबा प्याला मला पाहिजे ना आता बसायचं
I'm
तर
sorry about whatever disturbance we have. So we do erosive esophageal. So we do endoscopy and biopsy. So it will show presence of erosive esophagitis. If there is a stricture or Barrett's esophagus, it will be detected. If there is a hiatal hernia or ulcers anywhere, it can be detected. Esophageal biopsies can diagnose presence of reflux esophagitis on histology and it will rule out any allergic or infectious causes. And if there is a stricture, we can dilate the stricture. So management will be medical management. 50% of the patient will have long-term relief. In the remaining 50% of the patient will have to do surgery in the form of fundoplication. So this was in a older child with GERD. Then we will discuss about another condition, that a 5-day-old newborn who presented with bilious vomiting and abdomen was non-distended. So what are the possibilities in such a child? So it can be because of obstruction distal to D2. D2, the ampulla of Vater will open in the D2. So any obstruction beyond the second part of the duodenum, the child will have bilious vomiting. So any yellow or green vomiting means bilious vomiting. Bilious vomiting means obstruction distal to second part of the duodenum, and that means most of the time, if the vomiting is significant, the reason is surgical, and one needs to contact surgeon as early as possible so that it can be treated. Now, so obstruction distal to the D2, and it can be in the duodenum, it can be malrotation of bowel, it can be duodenal atresia or diaphragm, uh, or the obstruction anywhere in the small bowel can give rise to bilious vomiting. Now, investigation first investigation is the plain X-ray abdomen in a erect position. So here what you can see is a dilated stomach is there, the nasogastric tube is right there, then the duodenum is also dilated, and then you can see some gas in the distal bowel. So you know that this obstruction is not complete and it is at the level of duodenum. So the possibility is either malrotation of bowel, or there is a fenestration, or there is a duodenal diaphragm. So these are the two causes of duodenal obstruction, where there is a uh, fenestration, I mean where there is a partial obstruction. The other causes include superior mesenteric artery syndrome, where again it's a partial obstruction. So then one can do contrast study, but if this is in a newborn, we know that this child needs a operation, and one can go ahead and do the surgery, or one can do sonography, contrast study, CT abdomen. So in case if we do contrast studies, these are the findings which you will see. This is another patient where there is a stomach and there is a duodenum which is dilated. There is some gas in the distal bowel, again suggestive of duodenal obstruction. Here you can see barium, that's the duodenum, and you can see it, the DJ is not going, normally the DJ will cross, DJ means duodenojejunal junction, will cross the vertebral column, and DJ is at the level of pylorus or even higher than pylorus. So here what you can see is the small bowel loops are on the right side of the abdomen, and the DJ is much lower. So this is suggestive of malrotation and needs a urgent surgery. Here you can see the bowel loops are on the right and the colon is on the left. Another barium which is suggestive of volvulus. You can see that beaking sign. Again, not normal. The DJ is lower as well as on the vertebral column. Here again, you can see this is the patient with situs inversus. The stomach is on the right side and liver is on the left side. You can see that heart is on the left, but the stomach is on the right side. So the child has situs inversus. Now, normal rotation of bowel. So what is malrotation? So for knowing malrotation, we need to know what is a normal rotation. So normally when the child is in the womb, around 6th, 7th week, the bowel herniates outside the abdomen, and then slowly it goes back into the abdomen. So if this is a DJ flexor and this is the ileocecal area, and that's the umbilical area from which the bowel is herniated outside. When it goes back, it rotates by 270 degree in a clockwise direction. So DJ which was here, it will rotate by 270 degree and come to the left side of the superior mesenteric vessels. The ileocecal valve which was down will come here 270 degree into the right upper quadrant, and then will descend down into the right iliac fossa. So this is the normal rotation. So in normal rotation, superior mesenteric vein is on the right side. Inferior vena cava is on right side. So vein is on the right side. Aorta is on left side. So mesenteric artery, superior mesenteric artery is on the left side. So this is a normal rotation. Once you know the normal rotation, then we will know how to distinguish on the investigations like sonography. So on sonography, there is a reversal of normal anatomy between or relationship between superior mesenteric artery and superior mesenteric vein. So superior mesenteric vein will lie on the left side and artery will be on the right side. If there is a volvulus, there will be something like whirlpool sign, something like that. And it, so that is suggestive of basically volvulus. The same thing you will see on CT scan. So anatomic location of small bowel on right side, relationship of the superior mesenteric vessels are inverted. There is aplasia of uncinate process. There is features of volvulus obstruction gangrene, or there may be associated anomalies. So here what you can see is superior mesenteric vessels, and that's the mesentery which is rotating around the superior mesenteric vessels, suggestive of malrotation. So now we will see another video. So this was a small 10 days old baby who had bilious vomiting, and on sonography and on plain X-ray, it was suggestive of malrotation. We did not do any contrast study, but went in with the laparoscopic surgery. The weight was around 2.53 kilo. So even in a small babies, we can do laparoscopic surgery very well. Beautiful view we have. So all these are the bands. What we call is the LEDs band, which are going from large bowel over to the duodenum and going into the retroperitoneum. So we need to divide all these bands. And you want to make DJ flexor straight. We want to correct the volvulus. So there was a volvulus associated. What we are doing is pulling the bowel from that, so volvulus will get corrected and DJ will become straight. So in surgical principles, you want to make the DJ straight, then widen the mesentery so that the volvulus will not recur. So what we are doing is increasing the distance between small bowel and large bowel from where it is originating in a case of malrotation. So all these bends will be released so that the colon goes onto the left side. Yeah, these are the last bands which are we are releasing to widen the mesentery. So this was the DJ area, volvulus is corrected. The DJ is becoming straighter, straighter and straighter. The bowel will go onto the left side. So all these bands can be released. These are 3 mm small instruments. You can see nicely. This is what we call is a diathermy hook, and that is the best instrument for the pediatric surgeon. You can hook, look and cook, so you don't damage anything else. And at the end, we do appendicectomy because the appendix will be lying onto the left upper quadrant. So if the child develops appendicitis, it will be difficult to diagnose. So at the end, we will do appendicectomy. So we are still widening the mesentery. Once it is adequately widened, then we will see this is the pancreas which has come into the view. You can see nicely that is pancreas. We'll see the superior mesenteric vessels also, and that's the appendicectomy which is under the which is being done. So this is in case of malrotation of the bowel when they have bilious vomiting. It has to be operated early. If we don't operate early, they can develop volvulus and the entire bowel can die, and the child may not be able to survive that insult. We will discuss another case. It's a 3-week-old first-born male child where the vomiting was non-bilious. Now, non-bilious vomiting means the obstruction which is proximal to D2, and the commonest cause is pyloric obstruction or pyloric atresia or pyloric gastric paresis. So here this is a 3-week-old child vomiting projectile and non-bilious. Projectile vomiting, again, it does, the regurgitation is just it comes out from the nose and from the mouth. But here it is projectile, it goes far. So that is again suggestive of obstruction. Now the child is hungry to feed again after vomiting. That is again, it means that the child is otherwise fine. There is no medical cause. If there is some infection giving rise to vomiting, then child will not be hungry. Then the child is constipated and pellet like stool because not much of milk is going in the distal bowel, and because of that they get the stool gets hardened, and it becomes like pellet. On examination will be dehydration, abdomen will be distended in epigastric region. If you look carefully, there will be peristaltic wave from left to right, and if you examine it well, then uh, one can even see, even feel olive, that is palpable pylorus. And for that you need to have child which should be relaxed. Now, once you suspect that there is a pyloric stenosis, you have to admit the child and you have to send the investigation, which includes CBC, serum electrolyte, because of the vomiting there is going to be hypokalemic, hyponatremic metabolic alkalosis with paradoxical aciduria. Now, paradoxical aciduria meaning the child is having alkalosis, so you expect bicarbonate to go into the urine, but here the acid is secreted or lost in the urine. We will not go into details of that, why that happens. There is associated, we send venous bicarbonate level, because if venous bicarbonate level is very high, we will continue conservative management before taking the child for surgery. Once the bicarb level comes down significantly, then only we will go ahead with the surgery. On sonography, you will measure the pyloric muscles thickness and length. If thickness is more than 4 millimeter, it is diagnostic. Less than 3 millimeter is normal. In between is a borderline. If the length is more than 17 millimeter, it is diagnostic of pyloric stenosis. Barium meal was being performed in past. Today we hardly do that for diagnostic purpose. The treatment will include, the child should be fasting. We give IV fluid, nasogastric tube is placed. We give wash and then put some saline for the absorption, and treat gastritis and GR, which will be there along with this. And once the venous bicarb level falls less than 30, we will take the child for surgery. Surgery we do is uh, pyloromyotomy. We used to do it open. Today we do it laparoscopically. The advantage of laparoscopy is there are very small fine scars, and it is an elegant way of doing it, and operative time is, once everything is in place, it doesn't take more than 15 to 20 minutes. So here we are putting the instrument directly. Now that is the pylorus. You can see beautifully pylorus. These are the vessels. This is again same 3 millimeter hook. Now we have done the pyloromyotomy even in a child or infant which is weighing about 1.5, 1.7 kilo. This is a beautiful retractable knife. So with that, we will make an incision. That retractable knife, we can control the depth of the incision. You can decide whether you want to keep 2 millimeter, 3 millimeter. As you know, the pyloric thickness is more than 4 millimeter in most of the infant. So you are less likely to damage the mucosa. Now, once the incision is taken, we put this pyloric spreader to spread the muscles. You can see beautifully it is doing the job, and you can see the mucosa which is beautifully seen across, and we make sure we go proximally adequate, and distally we stop at the prepyloric vein of Mayo or white line. And then we check whether it is moving independently, because that will confirm that you have done adequate job. We start feeding after 6 hours and advance to full feed usually in 1 or 2 days, and most of the children will be discharged in 2 to 3 days. Uh, the results of surgeries, laparoscopy, are as good as open surgery or maybe better than that. Uh, Oral, we have already discussed. We start oral feed within 6 hours and full feed in 24 to 48 hours. Discharge home on second or third day. Now, this is another case, 1-year-old child who presented with vomiting for 6 months. and the vomiting was immediately after feed. Barium imaging was done and it shows a dilated esophagus. You can see here, there is a dilated esophagus. There is a red tail appearance. Here also you can see that. So barium imaging is a primary screening test, and it is suggestive of achalasia cardia. So diagnostic accuracy is approximately 95% to diagnose achalasia cardia. It typically shows a dilated esophagus that terminates in a beak-like narrowing caused by persistently contracted lower esophageal sphincter. In some cases, the dilatation is so profound that esophagus assumes sigmoid shape, and generally there is no air in the stomach. One can do manometry also. The advantage of manometry is you can divide it into three types. So type 1 is there is no pressurization in the body of the esophagus. In type 2, there is increased pressure in the body of the esophagus. In type 3, there is spastic achalasia. There is increased pressure in the body of esophagus, but it obliterates the lumen. So one can differentiate between these three types because the results of surgery will depend upon the type. Type 2 has the best results with 90% success rate as compared to type 1, where the 63%, and type 3 will have 33%. So it gives us general idea that which patient will do well with surgery. And again, manometry is not easily available everywhere, but in Bombay we have quite a few centers which can give us the manometry and we get it done. Now, in some of the patient, we do even scopy, and this is typically in adults. One should do it because you want to rule out the malignancies in adults. In children, generally you don't have malignancy, but you do it to know exact level of the sphincter from the teeth. So when we do scopy, we measure the distance uh, from the teeth of the lower esophageal sphincter. And when we have to put a sensor for manometry, we adjust according to the length so that our results are correct. Now, what is the treatment? So, no treatment is reliably restores the function. Nitrate, so medical line of treatment is not reliable and we generally don't do it. These are all recommended. One can try nitrates and calcium blockers, but they have limited success and we don't advocate it. One can do pneumatic dilatation, but again, the results are not very good in children and we don't advocate. And the problem with esophageal dilatation is that one can perforate the esophagus and then everything becomes very messy. If you do repeated dilatation, then when we have to operate, the chances of operative injuries are quite good and we don't recommend. The surgical results are very good and that is a primary line of management in children. Endoscopy and Botox people have tried and it has a limited time one can have relief of symptoms. So again, it's not been universally practiced. Then there is a poem. In poem, what we do is put a scope and about 5 to 7 centimeter proximal to the lower esophageal sphincter or esophagocardiac junction. You make an incision into the mucosa, and between the mucosa and the muscles, you create a plane, go right up to the lower esophageal sphincter, and then make an incision using the diathermy, and you go across onto the stomach side and make an incision very nicely. And uh, in adults, we have quite a few gastroenterologists who are doing it. In children, it is again, it's not very easy to do it and not many people can do it. The problem with the procedure is there can be subcutaneous emphysema, pleural effusion, pneumothorax, segmental collapse. And the problem is if we can't do this well endoscopically, when we have to operate, the chances of complication of perforations are very high. and we don't advocate because the results of surgery are very good. Now, when we have to do surgery, this is what we do. Again, like what we had seen in the fundoplication, we do dissection of esophagocardiac junction. Here you can see there is lot of periesophagitis, and because of that there were a lot of adhesions. Uh, so this is the lower esophagus is being dissected, and then what we are doing is separating the muscles of the lower esophagus. You can see beautifully that is being separated. You will be able to see the circular muscles. You can see nicely circular muscles. We need to divide all the fibers of circular muscles. You have to do this at least for lower 4-5 centimeter, and in adults we say as high as possible, 6-7 centimeter if possible. So all these fibers one by one we catch and keep on dividing it, so that you can see the mucosa nicely in lower 3 to 5 centimeter depending upon age, and on the stomach side you go up to a centimeter or so. So this is now we are working on the esophagocardiac junction, and the incision will be taken on to the stomach side. Now, when we extend the incision on the stomach side, there is always a possibility of creating a iatrogenic gastroesophageal reflux disease. So we will have to put, or we will have to do fundoplication, and that is what we are doing now. What we call is a anterior or door fundoplication. This is again 2-0 ethibond suture we took with the stomach, then we took with the diaphragm, the crura, left crura, and then the muscles of the myotomy. And that is rotated now onto the stomach side, so that it will create a high pressure zone on the lower esophagus uh, to to stop any vomiting which can happen or regurgitation which can happen. So that is a surgery for achalasia cardia. Then this was the last case which I am going to show. This is a 15-year-old girl operated for kyphoscoliosis, and after the surgery, of course, today's talk was on spinal deformity, so at least we will have little bit of that. So operated for kyphoscoliosis, but post-operatively the patient started bilious vomiting. So after actually the patient was discharged and came back in the ER, and then on investigation which was done, CT angio, because this is classical for SMA syndrome. SMA is superior mesenteric artery syndrome. In that, what happens, the duodenum, third part of the duodenum gets compressed between superior mesenteric artery and the aorta. So if that angle is less, then it is diagnostic of superior mesenteric artery syndrome. So initially we started with conservative management, but there was no relief. NJ tube, nasojejunal tube feeding was started, but there was no relief. So underwent laparoscopic duodenojejunectomy. So what you see here is this is the jejunum. We have opened the mesocolon to see the duodenum. So that is the duodenum. So that's the duodenum. So duodenum and jejunum are sutured together. Then we will make an opening in that, both the structure. So we are making an opening on the duodenum, and that's in the duodenum. So after the opening is created, we are putting a stapler. So stapler is being placed, and then we'll fire the stapler. So then both will join with each other. So that is joined. So now that superior mesenteric artery is on the left of this structure. So the food will go directly from duodenum into the jejunum, and obstruction is taken care of. Again, this is done using laparoscopy. So you can start feeding after a couple of days. We can do dye study, confirm that it is going across very easily, and then you can start feeding. The last case for today is a 2-year-old girl who presented with epigastric pain, nausea, fullness in upper abdomen. There was loss of weight over few months. So over last couple of months, the child had lost about 1.52 kilo, and then she came from Jodhpur to Bombay for the treatment. The barium was done, which was normal. CT scan showed dilated stomach, but there was no malrotation. Sonography was normal. Child was treated conservatively at Jodhpur, but there was no relief. So father was tired and he brought the child to Bombay. It was seen by pediatrician and referred to us. And on detailed discussion, we realized that this can be gastric paresis. And as the child was not improving, we planned the surgery. So what you do is a pyloroplasty. Now, typically, gastric paresis is very common in Jodhpur. We don't know why. Our colleague, Dr. K.K. Sharma, he described this condition as a Jodhpur disease, and they all do well once we do pyloroplasty. There is a conservative management in the form of antiemetics. We can try metrogel. We can try many other medicine like erythromycin also, which helps up to certain extent. Uh, but this is a complete relief. So what we did, we made an opening in the pylorus longitudinally, and we are suturing it uh, horizontally. So that is known as Hennig Mikulic's pyloroplasty. So which is being done, and we are going, this is a 40 PDS suture, which is relatively permanent, which is being used. We are going to put the second layer of suture. Again, this child, we did dye study after 2 days and then started feeding. And the child was discharged on day 5. It could have been discharged early also, but many parents, they don't want to go home. This child came back after 1 month with weight gain of 1.5 kilo. So this was the last case. If there are any questions, we'll be happy to take. So take-home messages will include detailed history, examination, and investigation. And it is important to discuss with the referring physician about what exactly the child has, and accordingly, we will have to investigate the child, identify the exact cause of vomiting. If we don't know and if we treat, then it is not right. We will not be able to give correct treatment. The management includes, we have already discussed the standard, and wherever the surgery is indicated, please don't delay it. Particularly the child with bilious vomiting, it is very important that the child should be investigated and treated as early as possible. If they have malrotation with volvulus, if we don't operate in time, the entire small bowel can become gangrenous, and then the child may not be able to survive. So any bilious vomiting, please make sure they are investigated immediately, referred immediately, and the proper care is being taken. If there are any questions, I'll be happy to answer. Thank you. I will stop sharing. Yeah. Avi, Pooja, are you around? I will unmute anybody. If you have question, you can unmute yourself and uh, ask the question.
Sir, for GERD,
Yeah.
in a big previously when H2 blocker and PPI were not available, they used to do vagotomy.
Yeah. So that era is over now. I mean, when I was medical student, we used to see vagotomy as well as a primary resident in general surgery.
Yeah.
we used to observe that, but today I don't think that is
Yeah, now laparoscopic surgery and PPI and H2 blocker and
so
newer
PPI.
medicines.
With PPI, I don't think there is any need of that. Of course, we do fundoplication as and when required, even in adults.
Yeah.
GER
And
is
sir,
quite common. GER as well as hiatus hernia in adults, and some of
height
them,
is a problem.
yeah.
Sir, H2 blocker from which age you can give?
Uh, we H2
Like
blocker we can give earlier also, but PPI we
Rantec,
delayed.
Rantec liquid is available.
Yeah, Rentec liquid is available. Only thing we need to remember the strength. It contains 25 milligram in 5 ml. So we can't prescribe 5 ml in a small child. We have
Yeah.
to give it in ml. Of course, Dr. Bharat Parmar is going to tell us about how to calculate doses and all this medicine.
Yeah.
But that is very important for all of us to remember.
Sir, which PPI is advocated in this GERD?
PPI means we use pentodic only in children most of the time, but we can use any. There is nothing that this can be used and other can't be used. But we try and avoid PPI because they are relatively high, and the complications are higher than using H2 blockers. So we try H2 blocker as far as possible, and only rarely we use PPI. Any
Any
other question?
relation of PPI with long use of PPI with cancer?
I think PPI can give rise to gastric adenoma, gastrinoma.
Okay.
Pancreatic tumor is known, secreting
Okay.
gastrin.
Noise
Hello.
from the.
Any other questions?
Do
No,
they
thank you,
use
sir.
cisapride in the infants?
Hello.
Do they use cisapride? Because in adults they are not using it because of side effect.
Yeah, so Cisapride can give rise to heart block. So it is not frequently used nowadays. Initially, we were using it, but not today. Cisapride, Mozapride, all that is rarely used. All the time is the domperidone or perinom.
Temporaneous is safe.
Uh, any other questions?
Thank you, sir.
Yeah, in antacids, generally we give mucin gel or viscous material. Uh,
So do they use alginic acid?
uh, it can be used. In fact, most of the time when the patient comes to us, they come for surgery. We operate and send it back to pediatrician and uh, our colleague gastroenterologist, Dr. Bharat Parmar can answer us.
Okay.
Gastric
Sucralfate
ulcer.
can be used. Sucralfate is a good antacid.
Yes, sir. Yes.
Eh, if there are no questions, then it is 3:30 also. We will request Dr. Bharat Parmar to take over.
Thank
Dr.
you.
Bharat
Thank you, sir.
Parmar,
Yeah.
yeah, will you be able to share screen from your
Yes.
side?
Yes. Yes. I'm sharing.
Okay. Dr. Bharat Parmar is a senior pediatrician associated with SRCC Children's Hospital, Haji Ali, and in addition, he has his own clinic at Opera House and at Nagpada. He is very active in social organizations like Lions Club and Jain Doctor Federation. He is president of National Jain Doctor Federation. Uh, and is well known in practice for last almost 35 years. And he is going to tell us about drugs and dosages in pediatrics. And as we were discussing that in children we have to be very careful about the doses, and it's very tricky for remembering all these doses and calculating that. So Dr. Bharat Parmar is going to show us how to calculate the doses and how to give that. Now, what I am going to do is again mute everybody, and at the end of the talk, we'll allow you to unmute on your own. So, Dr. Bharat Parmar, you can start.
Yeah, thank you, Rasik, for giving nice introduction, and thank you, SRCC and you, for giving me this opportunity to talk today about drugs and doses in pediatrics. Can you see my screen?
Yes, I can see.
And I'm audible also, no?
Yeah.
Yeah. It is very important to prescribe correct dose in pediatric age group because the less dose will not give results as desired, and overdose will cause adverse effect and toxicity. Now, simple basic, 1 teaspoon of measurement is 5 ml, half teaspoon is 2.5 ml, 1.5 teaspoon is 7.5 ml, 2 teaspoon is 10 ml, 1 tablespoon is 15 ml, and 1 ml is about 16 to 20 drops. So these are the basic measurement is required. When you prescribe medicine to a patient, you should always write 1 teaspoon and write 5 ml because sometimes people get confused. How many mLs to be given? And even you can draw a measure also. It is very important to prescribe correct dose in pediatric age group. Sorry. Now, average weight, because so many GPs are very busy in practice, you may not take weight also of so many children. If you take weight, it is always good, but you can have a rough estimate of weight of each child. Like newborn is averagely around 3 kg, 3 months, at the age of 3 months, we expect the weight to be 5 kg. At 6 months, around 7 kg. At 9 months, around 8 kg. At 1 year, around 9 kg. At 2 years, around 12 kg. At 3 years, 14 kg. And then 2 kg per year till the growth spurt starts in the boys and in the girls. In the girls, the growth spurt start early, 10 to 11 years, and the boys about 13 to 14 years. So there you expect a rise of 5 to 6 kg in a year. So roughly you can calculate the weight. Bigger the children, there is no problem. Only problem the smaller children. So if we remember till the age of 3 months, it's very simple. Whatever birth weight is there, it doubles at the age of 5 months, triples at the age of 1 year, 4 times at the age of 2 years, and then every year 2 kg weight gain. Now, when you're writing the prescription, you should always write 10 mg. Between 10 and mg, you should always keep a gap. Don't write 10 next to 10. Don't write mg because sometimes you get confused and patient may read 110 mg or chemist may get confused and may give some other medicine. I had one experience given glucon-D powder by sister written the discharge card only glucon-D and she didn't write powder. And the chemist read it glucobay and gave the tablet glucobay to child and child came with hypoglycemia to us. So sometimes clear-cut legitimate prescription is required and that's why I always keep a gap between the value and the strength. Then never place a decimal after milligram because 2.0, sometimes the decimal is not clearly read by the patient or chemist and the chemist may give 20 mg or the patient may give 20 mg. So I'll only write 2 mg, but always place a decimal and 0 before the ml because if you write 0.5 ml or it should be 0.5 ml, that is very clear cut because sometimes that point will not be read and patient will be given 5 ml doses. That is very important. Never abbreviate the word unit because the handwritten U or EU can look like a 0 also. And IU is not abbreviation for international unit. The handwritten IU can look like IV. So sometimes the problem can occur. Then always write clear cut OD once a day, BD twice a day, TDS thrice a day, QDS 4 times a day, HS at the time of sleep, SOS when required. And always write ml below the spoon. So 1 spoon, write down 5 ml. And you want to give 3 times, then write 1 3 times. If you want to give 2 times, then write 1 2 times. If you want to give 1 time, then write 1 time. So it will become very easier for the patient to give medicine. Now we start with the drugs, common drugs. I am not going to talk more of the which indication, where to use, because time is too short, and which commonly drugs are used in general practice. That only I am going to touch it. So first and common used drug, macrolide group of antibiotics commonly used in children, erythromycin. The available strength of the syrup is 125 milligram per 5 ml, and the dose is 40 to 50 mg per kg per day. Please pardon me, 125 mg, it's not ml. So 10 kg child, roughly you will give 5 ml 8 hourly. And if the child is smaller weight, you can give drops. So the drops available in the market is 1 ml is 100 mg. So for 1 kg child, you give 0.1 ml TDS. For 2 kg, you give 0.2 ml. 3 kg, you give 0.3 ml. 5 kg, you give 0.5 ml. And 10 kg child, you give 1 ml. So it becomes correct dose to child. Or if you don't want to remember this, then you can write 2 drops per kg per dose 3 times a day. So it becomes very simple, and you calculate correctly, it will become same dose you are giving to the patient. Second drug is azithromycin, the same group. The syrup available in the market is 100 mg per 5 ml, and the dose for routine infection like throat infection or skin and soft tissue infection, it is 10 mg per kg per day. And for 5 kg child, so you have to give 2.5 ml once a day, and for 10 kg child, you have to give 5 ml once a day. And if child is 20 kg, then either you can give 10 ml of the 100 mg, or you prescribe 200 mg syrup per 5 ml, that is also available in the market, and that you give 5 ml once a day. Only nowadays, typhoid, azithromycin also used in typhoid fever, and there we give little higher dose, and we give 20 mg per kg per day for about 6 to 7 days. So there you can give double the dose of the same amount. Then third macrolide group of antibiotics is roxithromycin. The syrup available in the market is 50 mg per 5 ml, and the dose is 5 to 10 mg per kg per day. And if you want to give 5 mg per kg, then the dose is 2.5 ml BD, mainly for skin and soft tissue infection, boils, it is used. Then the fourth drug in the macrolide group is clarithromycin. It is commonly used nowadays for atypical respiratory tract infection, and the dose is 15 mg. Sorry, pardon me, it is not 15 ml, 15 mg per kg per day. And the syrup available in the market is 125 mg per 5 ml. So you have to give 10 kg child, you have to give 3 ml BD. And if the child is 20 kg, you can give 6 ml BD, or you also get syrup in the market of 250 mg per 5 ml. So same dose can be given of clarithromycin. Then next group of antibiotics, broad spectrum antibiotics. Ampicillin nowadays not available, and we are not using it, but in past we used to use a lot. 50 mg per kg per dose, and the syrup available in the market were 125 mg and 250 mg per 5 ml. So for 10 kg child, we have to give 5 ml QDS, or for 20 kg child, 250 mg, you have to give 5 ml QDS. So this way, you can very easily calculate the dose in the practice. And if you remember for 10 kg, that is the base, then accordingly you can calculate. Suppose the child is 7.5 mg, then you can give 3.5 ml. If the child is 5 kg, then you can give 2.5 ml. If the child is 12 kg, you can give 6 ml. If the child is 14 kg, you can give 7 ml. If the child is 18 kg, you can give 9 ml. So whatever the weight, half of that. Simple, very simple. If you remember, for one weight, you can give exact dose. And if you calculate 10 into 50 is 500, 5 ml 4 times is 500. So you are giving accurate dose to a child, and very easy to remember. No need to use calculator, or if you are poor at mathematics also, then you can simply give. Amoxicillin, 40 mg per kg per day is the dose. Syrup available in the market are 125 mg, 250 mg, and drops are 100 mg per ml. So for the 10 kg child, you will give 5 ml 3 times a day. And for 20 kg child, you will use 250 mg syrup, 5 ml TDS. And for newborns and small children, you can give drops of the amoxicillin, 2 drops per kg per dose. So if child is 1 kg, give 2 drops, 5 kg, give 10 drops. Then co-amoxicillin, like Augmentin or any other brand, that contains 200 mg of amoxicillin and 28 mg of clavulanic acid, that is Augmentin Duo. And other is Augmentin DDS, that is 400 plus 57. So for 10 kg child, you have to calculate the dose of amoxicillin, not the clavulanic acid. So it is 5 ml BD, and for 20 kg child, you have to give Augmentin DDS 5 ml BD. So you can easily calculate the dose, and if similarly for 20 kg child, you have to give double the dose. The other commonly used drug which was used in past, but nowadays we don't use much commonly. Only we use as a prophylactic for urinary tract infection, or sometimes in resistant typhoid fever or other disease wherever we get sensitivity. Then we use cotrimoxazole. This is a combination of sulfamethoxazole with trimethoprim, 200 mg of sulfa and 40 mg of trimethoprim. The dose is 8 mg per kg of trimethoprim. So for a 10 kg child, you have to give 5 ml PD. So it is simple, 1 ml per kg per day. So if child is 10 kg, you have to give 10 ml. So divide into 2 doses, 5 ml BD. If child is 8 kg, then give 4 ml BD. If child is 12 kg, give 6 ml BD. If child is 20 kg, give 10 ml BD. Or you can give one tablet Septran single strength. So it becomes very simple in practice to calculate these doses. Nowadays, we commonly use in HIV patient also for prevention of PCP pneumonias. Next, chloromycetin not used so commonly in children, only reserved use for resistant typhoid fever. The dose is 50 mg per kg per day for typhoid fever. Other infections, they give 25 mg per kg per day. The syrup available in the market is 125 mg per 5 ml. So for 10 kg child, you have to give 5 ml 4 times a day. Then penicillin orally. Previously, we used to get some syrup also, but now only tablets are available in the market with the name of tablet Pentix, and they have different strength of 200, 400, and 800. So the full dose is 50,000 units per kg. So for 10 kg child, you have to give Pentix 201 tablet BD. For 20 kg, you have to give 400 mg 1 BD, and for 40 kg, you have to give 800 mg 1 BD. Then linezolid, especially soft tissue infections, staphylococcal infection, boils, or resistant cases, and children with pneumonia is very sensitive drug. After IV discharge, when patient on discharge, you can give oral also. The syrup available in the market at 100 mg per 5 ml. Dose is 10 mg per kg per dose. So for 10 kg child, you have to give 5 ml 3 times a day. Now the cephalosporin groups, the first generation cephalosporin, cephalaxin, Sporidex, vaccine, any other brand, whichever you like it, you can use it. The syrup available in the market is 125 mg per 5 ml and dose is 50 mg per kg per day. So for 10 kg child, you have to give 5 ml QDS, or you can give double strength 5 ml BD, or syrup 250 mg per 5 ml. For 20 kg child, you have to give 5 ml QDS. This is a very good drug for skin, soft tissue infection, and UTI and broad spectrum antibiotics. And the drops in the form of 3 drops per kg per dose TDS. In second generation cephalosporin, cefadroxil or cefadrox, or 25 to 30 mg per kg per day. The syrup available in the market is 125 mg per 5 ml and 250 mg per 5 ml. So for 10 kg child, you give 5 ml BD, and for 20 kg child, you give 5 ml BD of 250 milligram strength. Then cefaclor or distaclor, the trade name, 25 mg per kg per day is a normal dose for skin, soft tissue infection, throat infection, LRTI. So for 10 kg child, 125 mg per 5 ml syrup, you have to give 5 ml BD, and it is very good drug for resistant otitis media, because they have found high concentration in the middle ear fluid, and but there you have to give higher dose, 40 mg per kg per day, and you have a special syrup available in the market of 187 milligram per 5 ml. So for 10 kg child for otitis media, you can use that strength 5 ml BD, or if you want to use 125 wala, then you use 7.5 ml BD. So whatever you like, you can use it, but this is to simplify, I made this way. Then cefpodoxime, just two trade name Cefodem monosep, 10 mg per kg per day. The syrup available in the market is 50 mg and 100 mg. So for 10 kg, you have to give 5 ml BD, and for 20 kg child, 100 mg per 5 ml 5 ml BD. And the last in the second generation cephalosporin is cefuroxime. The dose is 25 mg per kg per day. The syrup available in the market is 125 mg per 5 ml. So for the 10 kg child, you have to give 5 ml BD. Now the third generation cephalosporin, which is commonly used nowadays, cefixime, the oral available Zifi, Taxim, anything. The dose is 8 to 10 mg per kg per day, and the syrup available in the market are 50 mg per 5 ml and 100 mg per 5 ml. So for 10 kg child, you have to give 5 ml BD, and for 20 kg child, 100 mg syrup, you give 5 ml BD. Only in typhoid fever, we give it high dose up to 15 to 20 mg per kg per day for 10 days. So there you can double the dose. And even the drops are available in the market, and the drops dose is 0.2 ml per kg per dose. It has to be given BD, or 4 drops per kg BD. So other antibiotics we give 2 drops TDS, but this antibiotics we give 4 drops BD. So 1 kg child 0.2 ml and 5 kg child 1 ml. So whatever way you want to remember, you can remember simplified formula. And the 4th generation cephalosporin ceprozil or Revzilo, that 15 mg per kg per day, resistant fever, typhoid. There you can use this. The serum available in the market is 125 mg per 5 ml. So like clarithromycin, this also be for 10 kg child, you have to give 3 ml BD. And for otitis media, you have to give double dose. This is also very good drug for otitis media. So there you have to use 250 mg per 5 ml syrup and 3 ml BD dose you have to give. And the last group of antibiotics are quinolones. Norfloxacin 10 mg per kg per day. It is only available in the form of tablets. Syrups are not available. Previously, with combination syrups were available with norfloxacin and metronidazole. That is also have been withdrawn from the market now. So the dose is simple. Use tablet 100 milligram, which is available in the market, half tablet BD. Drug of choice for urinary tract infection. Then for 20 kg child, you use 200 mg tablet, half tablet BD. So in one strip, the course is over for 10 days. And for 40 kg child, you use tablet 400 mg, half BD. So the full 10-day course is over. The second is ofloxacin 10 mg per kg per day. This is also good drug for diarrhea, typhoid, and other resistant infections. The syrup available in the markets are 50 mg per 5 ml and 100 mg per 5 ml. So for 10 kg child, you give 5 ml BD, and for 20 kg child, 100 mg syrup, you give 5 ml BD. And for typhoid fever, you have to give little higher dose, 20 mg per kg per day. The next is ciprofloxacin. The dose is 20 to 30 mg per kg per day. And we don't have syrup in the market. We have only tablets. So for 10 kg child, 250 mg tablet, you give half tablet BD. For 20 kg child, 250 mg, 1 tablet BD. And for 50 kg child, you can use 500 mg half BD. And other syrup available, levofloxacin, that is available in the market, L-Syn, levofloxacin. The dose is 10 mg per kg per day. So for 10 kg child, you have to give 5 ml OD. This is only OD drugs. Now, combination should be avoided because ofloxacin, one onidazole available, ofloxacin with metronidazole available, but the ratio is not proper because the ratio is different. Even ofloxacin 50 and metro is 100. So dose of metro is not given properly. So by and large, we don't use combination drug, and by and large, it is not required to use because most of the time in children, diarrhea are either viral or infective. Amoebic diarrhea in children are very, very rare. So mostly this combination is not required. Plus, it will cause even vomiting because most of the children diarrhea with vomiting is there. So giving onidazole is not required. Now only if it is amoebic dysentery or other oral infection or post-operatively you want to use, then you can use metronidazole. The dose is 30 mg to 40 mg per kg per day. For 10 kg child, the syrups available in the market are 200 mg per 5 ml. So you have to use 2.5 ml 3 times a day, or 20 kg child, then it is 5 ml TDS. Or you can give tablet also. Tablets are also available in the market, 200 mg and 400 mg, 1 TDS. So this finishes with the antibiotics and antidiarrheals, all the things. Now we go on to the next group, anti-malarials. See, most of the time, children with malaria, most of the time it is P5X malaria, and we have to give oral chloroquine syrup. That is Lariago is the brand. And the first dose is always 10 mg per kg per dose. That's the first dose. So for 10 kg child, you have to give 10 ml. So whatever is the weight, that much ml you have to give. So if the child is 10 kg, give 10 ml first dose. And the subsequent doses are half of the first dose. So second dose after 6 hours, second dose after third dose after 24 hours, and the fourth dose after 48 hours. So 10 ml, 5 ml, 5 ml. This is for 10 kg child. So if a child is 8 kg, then you give 8 ml, 4 ml, 4 ml, 4 ml. If the child is 20 kg, give 20, 10, 10, 10. If child is 16 kg, give 8, 8, 8, 8. It's become very simple and exact dose will be given. Otherwise, you will add half teaspoon, 1 spoon BD 2 times a day. I see so many prescriptions of different types. But this will give exact theoretical correct dose to the child. So first dose is 1 ml per kg and subsequent doses are 0.5 ml per kg into 3 doses after the gap of 6 hours, 48, 12, 24 hours, 48 hours. Or you can give after 6, 12, 24 hours. Then tablet quinine for resistant malaria, falciparum. Nowadays we don't use because of toxicity also. but just for knowledge, 30 mg per kg per day, we have strength of tablet available in the market, 100 mg and 300 mg. So 10 kg child, 100 mg tablet, 1 tablet TDS for 7 days. 20 kg you give 2 tablet TDS. And for 30 kg child, you give 300 mg, 1 TDS. Then the combination of artesunate and lumefantrine is available, especially for falciparum malaria. Their syrups are available and tablets are available. So up to 15 kg, you give 2.5 ml twice a day for 3 days. That is, second dose should be given after 8 hours. So first dose, then second dose after 8 hours, then 24 hours, then 36 hours, then 48 hours, and 60 hours. That way you have to give 6 doses. So to simplify it, 2.5 ml BD for 3 days. For 15 to 25 kg, 5 ml BD for 3 days. For 25 to 40 kg, 7.5 ml BD for 3 days. And for more than 40 kg, 10 ml BD for 3 days. Or you can give tablet also. Market the 40 milligram strength and 80 milligram strength available in the market. So for child 25 kg, tablet 1 BD for 3 days, same 0, 8, 24, 36. And more than 40 adult dose, 80 tablet, 80 milligram, 1 tablet twice a day. So this way you can give tablet also. Then Primaquine for prophylaxis, especially child who had Vivax malaria, you should always do G6PD. Nowadays, we all newborns do G6PD. So if in the file pediatrician mentioned that this is to the normal, there is no need to do again. But if it's not done, then before giving Primaquine, you must do G6PD to kill the gametocytes. And the dose is 0.3 mg per kg per dose. In the market, we have tablets available 2.5 mg and 7.5 mg and 15 mg. 3 strengths available. For 10 kg child, you can give 2.5 mg all tablet for 14 days. And for 25 kg child or 20 kg child, you can give 7.5 mg 1 tablet OD for 14 days. And for falciparum malaria also, to kill the gametocyte, we give a single dose of 0.9 mg per kg, single dose. So 10 kg child, you give 1 tablet. For adult, we give 6 tablets stats. Now anticox. It's very simple dose. Nowadays, we give 4 drugs to any child who has got diagnosed with cox. Rifampicin for 6 months, Isoniazid for 6 months, ethambutol for 6 months, and pyrazinamide for 2 months. So first 2 months you have to give 4 drugs. So you have available in the market 3 drugs combination for children. You don't have 4 drugs combination like in adult. You have AKT4, but you have only 3 drugs combination. And so the 3 drugs combination is Macox ZH, or even take Arsenex or Rifaicid, or so many brands available in the market. Whichever you want, you can choose. Which contains INS 50, rifampicin 150, and pyrazinamide 250. So for 10 kg child, you have to give 1 tablet once a day before breakfast for 2 months. So after aggressive phase of 2 months, along with ethambutol, and then after 2 months, we change over to 2 drugs combination, Isoniazid and rifampicin. The 2 drugs combination available in the market is Macox Plus or any other brand. Isoniazid 50 and rifampicin 100. So 1 tablet before breakfast for 4 months. Along with, you have to continue with ethambutol. And after 40, we generally give adult regime. So ethambutol dose is 15 to 20 mg per kg per day. In the market, you have no syrups, only tablets. So we have a strength of 200 mg, 400 mg, 600 mg, 800 mg, 1000 mg. So roughly for every 10 kg, you have to give 200. So 10 kg child, you give 200 mg tablet. For 20 kg child, you give 400 mg tablet. For 30 kg child, you give 600 tablets. For 40 kg, you give 800 mg tablet. And for 50 kg or adult, you give 1000 mg. So these are available in the markets, all the strength with Combutol, Semibutol, any brand you can take. And you can use simply this 1 tablet at night time for 6 months, and always keep an eye check of it. Then we come to common drugs, antipyretics. Commonly we use paracetamol, 10 to 15 mg per kg per dose. Ideally, if the high fever is there, the antipyretic dose is 15 mg per kg per dose instead of 10. With the 10, the fever does not go down. And even for pain also, the dose is 15 mg per kg per dose. And the syrup available in the market are 125 mg per 5 ml, then 250 mg per 5 ml, and drops are 100 mg per ml. So these are the 3 strengths available in the market. So for a 10 kg child, you can give 5 ml to 6 ml. If you want to give 10 mg dose, then you have to give 5 ml. And if you want to give 15 mg dose, then to give 6 ml QDS for a 10 kg child. It can be given as frequent as 4 hourly also, but ideally it should be given 6 hourly. The figure is very high, you can give every 4 hourly also. And similarly, drops, if you want to give for a small child, 2 to 3 drops per kg per dose, or 0.1 to 0.15 ml per kg per dose. Simple formula. And for bigger children, you can use 20 QDS or DS syrup. Any DS you can use. Market so many DS syrup available. Crocin DS, Calpol 250, Fuago DS, anyone you can use it. The other antipyretic or painkiller can be used the mefenamic acid. The dose is 5 mg per kg per dose. In the market, you get syrup Meftal P. It is only mefenamic acid, which contains 100 mg per 5 ml. So, for 10 kg child, it is 2.5 ml 3 times a day. Or you can use combination of ibuprofen, paracetamol. The dose is 10 mg per kg per dose, which contains 100 mg of ibuprofen and 125 mg of paracetamol. For 10 kg child, the dose is 5 ml TDS. Ideally, it should be avoided, especially in viral infection, dengue, all this fever, because it can cause thrombocytopenia. Unnecessary drugs should be avoided, can cause acute precipitation of asthma and all. So, paracetamol are safer. If high fever, you can use mefenamic acid. So, dose is simple 0.5 ml per kg per dose. For 10 kg, you give 5 ml, 8 kg 4 ml, 6 kg 3 ml, 12 kg 6 ml. So, roughly, you can calculate the ibuprofen dose simply just by remembering 0.5 ml. जितना weight उसका आधा dose दे दो. Okay. And now we comes to antiemetics. Commonly in the small newborn child vomiting, as Rasik has already told about GR and all these problems. Nowadays, the role of antiemetic not much there. Propped up position or H2 receptor antagonist is important. But you can give dome-style baby drops for symptomatic improvement. And the drop is very highly concentrated, 10 mg per ml. So the dose is even half to 1 drop per kg per dose 3 days. Even 1 drop is more. You can give half drop also per kg per dose 3 times a day before feed. But syrup is only 2 mg per 5 ml. So 0.15 to 0.1 to 0.3 we use. So 2.5 ml 3 times a day. Only citron, same dose 2.5 ml 3 times a day for 10 kg child. So this takes care of vomiting. Then we have a probiotics for diarrhea patients. Neutrolin B syrup orally available for 10 kg child. We give 2.5 ml BD. For 20 kg child, we give 5 ml BD. And other liquid residues you have in the market, all probiotic like enterogermin or progermin, anything you can use. Econom sachet or anything. 10 kg child, you give 1 sachet BD for 3 to 4 days. Then for symptomatic improvement, sometimes we can use residotril or enough sachet. The dose is 1.5 mg per kg per dose. For a 6 to 7 kg old child, we can give 1 sachet 3 times a day. For bigger children, we can use enough 30. For 10 kg child, you can do half sachet 3 times a day. Along with it, zinc is the best drug which can be used. And more than 10 kg child, you have to give 2.5 ml BD, 20 mg per day. And for a smaller child, less than 6 months, you have to give 10 mg. Zinc syrup, zinc drops available in the market. Now, constipation is a common problem. And by and large, it is always a habitual constipation. But before that, if the child is have failure to thrive and all this, then we should rule out the secondary causes, commonly surgical cause or hypothyroid. But otherwise, 99.9% the commonest cause of constipation is habitual diet and lack of water content or only milk diet. So counseling is very important for the family. Only medicine will not play a role more than medicine. The diet and the food and water intake will be very helpful. But to give symptomatic relief and to start the bowel habits, we have to give some drugs because of chronic constipation. The anal area gets eroded and get got fissure and it's very painful. So the child holds the stool because of fissure. So we have to make the stool little lighter so the stool passes easily and the fissure is healed, and later on then child can be shifted to normal diet. So lactulose syrup is safe to be used in children. 0.5 ml per kg per day is the dose. So 10 kg child you give 5 ml. You can go up to 1 ml per kg also. The other good formula available is oral PEG, polyethylene glycolate, either powder or syrup. Both are available in the market. So less than 5-year child, we give 1 scoop, mix in a glass of water, lukewarm water, and give it to child. Slowly, child can take it. Or syrup less than 5 years, 12.5 ml of syrup plus 50 ml of water. The bottle is available with the, but the small glass is available with the syrup in the market. Or more than 5 years, you can use 25 ml plus 100 ml of water. As the child feels better, then gradually you can come down on the dose. Don't stop abruptly. This can be continued for about 15 days, 1 month, sometimes 2 months, 3 months also. Because sometimes chronic constipation takes long time to get cured. You stop again again the child gets fisher. So vicious cycle sets in. So you have to break that cycle, then only the constipation will hit. No doubt, diet plays very important role. If not better, then send it to Dr. Rasik or any other surgeon so that they will take care of. Cremafin plus nowadays, Cremafin plus we don't use much in the child, but it can be used child more than 2 years or 5 years. The same dose, 0.5 ml per kg per day. For more than 2 years, 5 ml dose. Then for colicky child, so many times you must be getting phone, child has got distant abdomen, gas is there. Symptomatic treatment, any drops you can use 2 drops per kg per dose 3 times a day. For 5 kg child, you have to give 10 drops, 0.5 ml. Then for worms, deworming, albendazole, any brand, less than 2 years, you have to give 200 mg, that is 5 ml of syrup once a day, only once dose, single dose. More than 2 years to any age, 400 mg like adult dose, 10 ml stat. Mebendazole for any child, same dose, 5 ml twice a day for 3 days. For all age, about 2 years, like adult dose. Then, after finishing all the antibiotics and all these common drugs, now we come to the common cold cough in the practice. And so many children comes to you with cold cough. So any newborn child who comes with, small child comes with cold. So first you make it sure that it is running nose and there is nasal discharge, then only the medicine requires nasal decongestant. Lot of the time, the child comes with noisy breathing sound. And this is because of laryngotracheomalacia or short neck or child sleeping in the flex position or just the nose may be blocked. Then the oral medicine not required. You have to just put the drops in the nose and keep the child properly in either prone position or just put any saline drops. Otherwise, if you want to give medicine, if the nasal discharge is there, then you can use any nasal decongestant. So many brands are available in the market. I just written one brand. Timinic drops, Sinarest drops, Nextra drops, but used without paracetamol. So all these Sinarest AF drops or Vicoril AF drops are available in the market. So 2 drops per kg per dose 3 times a day orally. There is no duration for 2 to 3 days. That is better than stop it. Or similarly for bigger children, you have a syrups available in the market. Sinarest, Vicoril, anything. For 10 kg child, you have to give 2.5 ml TDS, and for 20 kg child, you have to give 5 ml TDS. Now for dry cough, if child is coming with dry cough or just simple with the cold associated with cough, then you have many dry cough syrup available in the market like Alex, Junior, Amrolide D, Tixilix. You can use any of this syrup. 10 kg child, 2.5 ml 3 times a day. And for wet cough, but without any wheezing or ulcers, just mucolytic with antihistaminic, then Amrodil Plus or Dilosin Expector or any other Z expector. For 10 kg child, 2.5 ml 3 times a day. All these cup syrup dose is 10 kg, 2.5 ml, 20 kg, 5 ml. Then if the child has a wheezing and it is productive cough and recurrent history of wheezing is available, then you can give salbutamol or levosalbutamol. Levosalbutamol does not cause any tremors, less incidence of tremors. So 10 to 12 kg, 5 ml 3 times a day. And for a smaller child, newborn or bronchiolitis child coming to you, then you can use, there's a wheezing, then you can use drops, Kufrin or Brozid, 0.2 ml per kg per dose. So 5 kg child, you will give 1 ml. Then for allergy, you can use or just symptomatic treatment for even running nose. Sometimes antihistamine doesn't work, then you can go to this group of drugs, cetirizine or fexofenadine. And the dose for 10 kg child is 2.5 ml BD. And for urticaria, severe rash, you can use sometimes Atarax 2.5 hydroxyl in 2.5 ml 3 times a day. Or for severe allergy or asthma, which are not responding, then you can use prednisone syrup or any other Omnacotil or any brand. The dose is 1 to 2 mg per kg per day. Omnacotil syrup available in the market is 5 mg per 5 ml. Even Omnacotil port is also available, 15 mg per 5 ml. So for 10 kg child, you can give 5 ml BD, or if you want to give TDS, then 3 ml TDS. That is 1 mg per kg dose. If you want to give 2 mg per kg dose, then you can give 5 ml QDS or 6 ml TDS. And similarly, Omnacotil drops, that is 5 mg per ml. So 1 to 2 drops per kg per dose. If you give for 4 to 5 days, then no need to taper. If you want to give for longer time, then you have to taper. So this finishes all these common drugs. Then I just forgot to add in the slide about Rentec, which Rasika was talking about dose. So if dose of Rentec is 5 mg per kg per day. So for a child of 10 kg, you have to do 3 ml 3 times. once a day. The dose is 0.3 ml per kg per day, or you can use lansoprazole tablets available in the market. Dose is 1 to 2 mg per kg per day. So roughly for 15 kg child, you give one tablet, or you can give little less tablet for a smaller child. And even you get powder also, esmoperazole or esol, that is 10 mg sachet. So one sachet for 10 kg child. If child is 10 kg, you can give one sachet a day. So these are all H2 antagonists. Then anti-epileptic drugs. I am just taking only 3-4 drugs. I am not taking more drugs. The dose of phenobarbital, commonly used drug Gardinal, 3 to 6 mg per kg per day, and you get syrup in the market. The strength available is 20 mg per 5 ml. So for a 10 kg child, it will be 5 ml BD. Then you can gradually increase if the conversion not stop. Let it be increased by a neurologist. Diphenylidentine or aptoin syrup. The dose is 5 to 8 mg per kg. Average you take 6 mg. The syrup available in the market is 30 mg per 5 ml. Then 10 kg child you have to give 5 ml BD. Then valproic acid or valproate is commonly used anti-epileptic drug, especially atypical febrile seizure or family history of febrile seizure. Then the child is getting recurrent seizures, then EEG abnormal. Then we put the child either on the valproate or Levipil. The dose is as low as 10 to, you have to always increase the dose gradually. So you start from 10, 20, 30, 40, and you can increase gradually. Highest you can go up to 80 mg also. So syrup available in the market is 200 mg per 5 ml. So for 10 kg child, the starting dose is 2.5 ml twice a day. Then you can gradually increase if child gets recurrent seizure and doesn't respond. Then you will add second drug, or better to refer to a neurologist, pediatric neurologist, and he will take care. Then carbapazine, especially drug of choice for focal epilepsy, 10 to 40 mg per kg per day. Syrup packet all available or tablets available, 150, 300. For 100 mg per 5 ml syrup, dose is 2.5 ml BD starting dose, then gradually you can increase. Only caution about syrup is there are a lot of sediments in this carbamazepine syrup, so always shake the bottle very well. Otherwise, last dose will be with of sediments and can cause toxicity problem. So always tell the patient to shake the bottle very well and give the syrup. Then for eosinophilia, diethyl carbamazine citrate, vanoside always used to be given along with the deworming. So 6 mg per kg per day. Syrup available in the market is vanoside, 50 mg per 5 ml. So 10 kg child you do 2.5 ml BD for 21 days. And for tropical eosinophilia, sorry, the spelling mistake, tropical, 12 mg per kg per day. So double dose you have to give. Then the diuretic, the furosemide, 1 mg per kg per day. Tablets available of 40 mg, but you have a drops available in the market, 10 mg per ml. Drops available, furopate, the drops available in the market, and that is to be given for 10 kg 1 ml. Then vitamins. Commonly, what vitamins to be given? Everybody is confused whether to give or not to give. Ideally, just for satisfaction of patient, sometimes you write multivitamins, but this is must. A vitamin D to all newborns up to 1 year or maybe up to 2 years. The initial dose is 400 international unit daily. For 1 year, you can continue up to 2 years, because in India, most of us are vitamin D deficient. And available now market, there are two strengths available. One is 400 international units and one is 800 international units. So you should be very careful. You should know whether you are prescribing 400 wala syrup or 800. So if it is 400, then you will give 1 ml, and if it is 800 IU, then you will give 0.5 ml. And that is to be continued till 1 to 2 years. Now there are few multivitamins which contain vitamin D also. So then if you are giving multivitamins like Vicinial Z drops, not the Vicinial plain drops, Vicinial Z or Zincovit. These two multivitamins contains 1 ml of 400 IU. So if you are giving Vicinial Z drops, then don't need to give separate vitamin D, because it has 400 IU of vitamin D. So once you stop this by 3 months or 6 months, then you can switch over to plain vitamin D. By and large, if the child is on breastfeed, then it is not required. Only vitamin D is more than enough. The other multivitamin syrup for bigger children, the parent wants or anything, then better to choose which has got broad spectrum multivitamins. like Zinkovic CL, B1, A2Z, anything. For 10 kg child, you give 2.5 ml twice a day. For 20 kg child, you give 5 ml twice a day. Then elemental calcium. Generally, you have to give calcium syrup in a newborn. If child is exclusively breastfed and mother is taking calcium, then no need to give extra supplemental calcium. Only vitamin D is required. But if you want to give oral supplement, then osteocalcium contains 80 mg per 5 ml, antiviral calcium, Mecalvit contains 90 mg per 5 ml, Mecalvit plus contains 250 mg per 5 ml, and calcium XP is 250 mg per 5 ml. So if you at least have to give 50 mg per kg per day of elemental calcium. So smaller child you can give osteocalcium, little bigger child you can give Mecalvit, or bigger children you can give any other brand, but you should know the content of elemental calcium, then it is worth giving. Otherwise, there are so many syrups available in the market, calcium, but they contain only 150 mg in 15 ml or in 10 ml. Then really you are not giving proper dose of calcium. So at least give the proper elemental calcium. The salt dose is not important. Elemental calcium, how much is more important? Then iron. So any child who is anemic, we have to give iron supplementation at least for 3, maximum 6 months to fill all the reserves and everything. And dose of elemental iron to be given is 6 mg per kg per day for 3 to 6 months. Now there are various syrups available in the market, and they all Orofer, Ferrium, Ferromia, Bitcofer, they all contain 30 mg per 5 ml of elemental iron. So for a 10 kg child, you have to give 5 ml BD for 3 months. Then we have a tonoferon pediatric syrup which has got highest strength of elemental iron, that is 80 mg per 5 ml pediatric. And there is also one plain tonoferon syrup which has got 250 mg per 5 ml of elemental iron. So you should know and then give according dose, otherwise the stool will be dark black color and constipated. So for 10 kg child, tonoferon pediatric dose will be 2 ml BD, and for bigger child, if you want to give proper dose and child is not taking oral tablet, then you can give tonoferon pediatric syrup for 20 kg 2.5 ml OD, and for 40 kg 5 ml OD. And even tonoferon drops are available. 1 drop is equal to 1 mg. So 3 drops per kg BD dose, or 1 kg is equal to 3 drops BD. 2 kg 6 drops BD. So each drop is 1 mg. So you have to give 6 drops to a child of 1 kg. Okay, I think I've covered most of the drugs which are commonly used by all the general practitioner, and besides there are many drugs, but it is not possible to discuss in 1 hour time. But these are the common drugs which are routinely used by even pediatricians and by general practitioner, and it can make simplify your doses. I will just give one practical. If you now analyze everything and you see the most of the syrup for 10 kg child is 5 ml, either it is OD like azithromycin, or BD like cefadrox or augmentin, or TDS like amoxicillin, or QDS like cephalosporin, or even paracetamol cough syrup. So if you remember how much to be given for 10 kg, then you can derive roughly for other weight also. And it becomes very easy. Like azithromycin, suppose you know 10 kg child, you have to give 5 ml. If it is 12 kg, then you give 6 ml. If it is 14 kg, then 7 ml, and you will exact dose. For malaria also, as I told you, 10 kg malaria go 10 ml, 12 kg 12 ml, 14 kg 14 ml, and similarly you can derive the dose. So it becomes very simple, and you give proper dose, no need to calculate also, and become very simple. Only thing you should know weight, and roughly if you know the weight, then you can do proper calculation. Any other question or any drug which is missed out and you want to know those, you are welcome to ask the question. We have 10 minutes.
Sir, levocitrazine, sir.
Huh?
Dose of levocitrazine in pediatric.
Levocitrazine, 10 kg child, 2.5 ml once a day.
Thank you, sir.
It has to be given only once a day, not twice a day.
Sir, sorry, I missed the dose of H2 blocker and antacid.
Antacid for 10 kg child like mucingel or sucralfate, you have to give 2.5 ml 3 times a day. For 20 kg, you have to give 5 ml 3 times a day. Rentec for a 10 kg child about 3 ml, and or you can give junior Lanzol tablet for 15 kg child, or 10 to 15 kg one tablet, or 15 mg tablet.
Okay. Thank you.
Sir, dose of Asthalin nebulizers and corticosteroid nebulizer, asthma.
By and large, we use Asthalin rescue solutions in the available. It's a 5 ml bottle, so you take 2 drops of the solution, 4 drops of solution plus 2 cc of normal saline, and that can be used for a nebulizer. For a smaller child, you have a combination of ipratropium bromide, LD dose, low dose, duolin LD, and you have Budocort 0.5 mg. So you can use combination of both, or you can use separately. For a 10 kg child, you give LD dose of 1 rescue and Budocort 0.5 mg 1 rescue.
Sir, nowadays erythrocin is used.
Sometimes it is used, especially I have found very good for chlamydia eye infection. When the child comes with milky purulent discharge from the eye, chlamydia, it's a drug of choice for atypical respiratory infection, or basically chlamydia is very good drug of choice. Chlamydia uveitis, yeah.
Because of arrival of azithromycin, nobody use it.
I know, but I have to cover all the drugs, but I still use for chlamydia eye infection.
Okay, sir.
And
Thank
we
you.
do see in children with milky, purulent, yellow discharge from the eyelid. You press the eyelid and but the pus comes out. It's very scary. And there it is very good drug.
Sir, how safe is it clarithromycin in child?
It is safe, very safe.
Okay, thank you, sir.
Only thing it is to be used BD dose.
Okay.
And 15 mg per kg per day is the dose. So it is little like more than 2.5, 3 ml twice a day.
Sir, safe steroid application for eczema and all, safe steroid application.
Hydrocortisone is the safest available steroid to be applied locally. Hydrocortisone. Plain hydrocortisone.
Brand name.
Sir, dose of antispasmodic, cyclospam, routine.
Sorry, I forgot that. 10 kg child, cyclopam 2.5 ml 3 times a day. 20 kg 5 ml 3 times a day.
And what about drotin?
Same dose. All antispasmodic, same syrup, same dose. 10 kg 2.5 ml, 20 kg 5 ml 3 times a day.
Thank you, sir.
So there are a couple of questions.
Sorry.
Sir, for
bedwetting, first you have to rule out whether it is a primary or secondary. Most of the time, it is a primary nocturnal neurosis where the child was never wet, never dry and continuously is just passing urine. If it is secondary, then you have to investigate. So normally, by and large, till the age of 5 years, bedwetting is normal. You don't have to treat or you don't have to investigate. But after the age of 5 years, the child still continues to vomit. Then the toilet training is important, and to prevent bedwetting, you should start toilet training earlier, as low as the age of 1.5 to 2 years. So if the toilet training started earlier, by and large, the child does not get bedwetting. But suppose the child gets bedwetting, most important to improve the home environment. First, to see whether bathroom is in the bedroom only or bathroom is outside, because the child may be scared to go outside in the night and do urine. That's why he passes urine in the bed. And keep the child give less water before sleep. Like child sleeps around 10 o'clock, then after 8 o'clock, stop liquids. Because if you give a lot of liquids, then the natural child is going to pass urine. Make him pass urine once before sleep, and maybe after 2-3 hours, again make him pass urine. The alarm beds are available, but not very practical. Then at last, we can use amitriptyline drugs available in the market, and that can be used for 1 month to 2 months. If child is better, you can use for 3 months also. And very rarely we use even the minirin drops or minirin tablets, but very rarely. Now, if it is secondary, then you have to rule out the cause. Then according to cause, you will.
Sir, oral antifungal.
Oral antifungal, by and large, we use fluconazole, Zucon tablet, or the market available is the dose 6 mg to 12 mg per kg per day. Tablet available in the market is 50 mg, 150 mg, and 100 mg. So for 10 kg child, 50 mg one tablet. For 20 kg child, you can use 100 mg tablet. For 25 kg, you can use 150 mg tablet.
So what about antivirals?
Antivirus, by and large, only used for this herpes infection.
Yes.
Zovirax acyclovir is available in the market. 20 mg per kg per day you have to give in 3 divided doses.
Sir,
Or for swine flu, we can use oseltamivir for less than 15 kg, 2.5 lbd.
dose of
Thank you,
Iterex,
sir.
sir.
हाँ बोलो बोलो.
Dose of Iterex.
I said no, 10 kg child 2.5 ml or 1 to 2 drops per kg per dose.
Okay, thank you, sir.
Thank you,
So
sir.
there's one more question on the chat. So one more question on the chat. What would you prescribe for a constipation for a child less than 6 months?
See, basically, if you take the history, if the stools are soft, then no need to prescribe. And exclusive breastfed child, it is normal constipation. Even the child passes after 5 days, and the stools are soft, and the child does not strain, and child does not have any symptoms, no need to treat any child who is constipated on breastfed. But if child is having problem, very hard stool, sometimes stools with the blood streaks or a lot of gas, then you can use lactulose is a safer bet because it is not absorbed. That is a safer bet.
Okay. So I had one more question for cough cold, viral-like symptoms in younger children. Under 2, it's a little unsafe to give a cough cold medication for fear of the sedation and other side effects. So what else do you recommend, like amongst home remedies, especially anything that absolutely will work or things that need to be avoided?
Honey, ginger, milk, turmeric powder, steam, those things can be given. And if you give proper dose, then sedation is not there. Like a 10 kg child, if you give any antihistaminic dose 2.5 ml, then sedation is not there. For a small newborn, if you give 1 to 2 drops per kg, then the sedation is not there. But if it is running nose, then only give. Only just for noisy breathing sounds. Some children have noisy breathing for 3 months. Till they grow, then it becomes less. So then the position is very important.
Okay, sir. Okay, sir. Sir, I think we have no more other questions. Thank you for the excellent talk and for answering all our questions.
Only one message is very simple. Just remember 10 kg dose and you can derive all the formulas.
Okay, sir.
Yeah.
Sure. Okay, sir, on behalf of the SRCC Masterclass Organizing Committee, I thank you very, very much for this lecture. So we can move to our next speaker now, to Dr. Sneha Shah. Thank you very much again, sir.
Thank you. Thank you very much.
Thank you, sir. So we'll move to our now we move to our last speaker for our masterclass, Dr. Sneha Shah. She is our pediatric ophthalmologist at SRCC Children's Hospital, and she will be talking about watering of eyes in a child, the what, why, and when. Welcome, Dr. Sneha.
Thank you so much. Thank you for inviting me to speak on this topic. But before I speak, I must thank Dr. Bharat Parmar for such a wonderful session and simplifying things. Even as an ophthalmologist, I feel that I can probably give the right dose to my children without checking with my pediatrician if I forget the next time. So thank you so much, sir. And yeah, sure. Are you happy for me to?
Dr. Bharat Parmar, you can stop sharing so that Sneha can share her screen. Hello. Hello. Bharat. Hello. Yeah. Sneha, you can take over.
All right, fantastic. So I'll just so I just want to check if you can see my screen now.
Yeah, we can.
Fantastic. All right. So thank you for the introduction. I'm Dr. Sneha Shah. I basically practice oculoplastics, which is plastic surgery around the eyes and especially in pediatrics. And my topic for today is managing watery eyes in children, the what, the why, and the when of it. I think this is one of the very common presentations, and I'm sure each and every one of you has seen a child with watering eyes. And of course, I don't mean this kind of watering. This of course, are much more tricky to treat and manage. But what I'll be talking about are more of the medical causes. Uh, the outline of my talk is going to be basically the causes. What all do you need to think about when you see a child with watery eyes? How do you go about establishing the diagnosis? And lastly, a small note on how we manage congenital nasolacrimal duct obstruction is in this day and age. So the aim of my talk will be primarily, to help you assess the cause, because a lot of it can be managed and treated at the primary physician level, uh, but at the same time, you must know when to refer them forwards. So, what causes watering of eyes, and what do you mean by watery eyes? So, in my head, I am thinking it's either overproduction, like there's too many tears being produced, or there's an obstruction somewhere in the outflow path, which is resulting in overflow. So now let's look at obviously always good to classify think, and especially in children, you must always keep the possibility of congenital disorders versus acquired disorders as well. And it is not essential that a child at say 3 months of age or 7 months of age starting to present with watery eyes, it still could be a congenital problem. So please do not rule out congenital disorders just because they present later in life. Um, and again, as I said, it could be either an overproduction or an obstruction. So some of the congenital causes are as listed, like overproduction due to irritation from eyelid issues, such as an epiblepharon, dysstachiasis, a rolled in eyelid, also known as entropion, or poor lid closures, as in children with congenital ptosis and the eye is not closing completely. Some of the causes for obstructive congenital causes are any problem anywhere in the lacrimal drainage system, starting right from the punctum, which is like the punctal agenesis, going on to a canalicular obstruction, or much more commonly, a nasolacrimal duct obstruction. Another entity which must be kept in mind is congenital glaucoma. Amongst the acquired causes for watery eyes, think of any kind of an inflammation or an infection or an irritation. So basically, three eyes is what you are thinking of. Is it what is irritating the eye? Is it a foreign body? Is it an abrasion which the child might have had? Is it some kind of an inflammation like blepharitis, keratitis, or an infection like a conjunctivitis? And again, of course, an obstruction can be acquired in the form of either a cicatrization or an acquired nasolacrimal duct obstruction later in life. Now, I'd like to go through some of the clinical presentations, which you commonly see in your clinic every day, and what were the causes in these children. Now, this very common presentation, clinical presentation, is a young child, usually 5, 7 months of age, and the mother says that he's had a watery eye, usually and more commonly on one side, since many months, but now it has become red and swollen. So this is a typical presentation of congenital nasolacrimal duct obstruction. You can notice the slight redness and swelling around the right lower lid. which is nothing but the inflammation around the around the lacrimal sac. Now look at the eyelid features which can result in watery eyes. Now the first picture, you see that the eyelashes are turning in towards the cornea, and you may even notice some scratches on the cornea. Now this is a congenital entropion. It is quite a rare entity, but something that you must think and look out for. As opposed to, if you notice in the second picture, which has the red reflex here, is that there's a complete there's a complete row of eyelashes which are present on the inner surface of the eyelid, and they are very thin and resting along on the cornea. However, in this case, if you notice that there are no scratches on the cornea, and hence these lashes are not irritating. So if I see these two children or these two infants, I would definitely advise some kind of intervention for the first child where the lashes are completely turned inwards, but maybe no intervention for the second child, because most likely that is not the cause of watering in this child. Now, if you see this full face picture of a child with blepharophimosis syndrome, this is a very severe type 2 disease wherein you have a severe ectropion as well as ptosis, resulting in incomplete closure. The child already has developed exposure keratitis and opacity over the corneas. And so the cause of watering in this child is multiple, right from incomplete eyelid closure to ectropion and keratitis. Now, this is a little more rare presentation wherein the child had congenital ichthyosis, resulting in a cicatricial ectropion of both eyes and both upper and lower lids. Because the child had excellent Bell's phenomena, the cornea of the eyes was not affected at all. We just recommended measures such as lubricants, conservative measures, and with treating the skin as well as the eye. After a few months, the child is looking much better and without having any complications of the eye. Now, it must be impressed upon that the parents are well educated to notice what are the potential complications and what to look out for, and not delay in bringing the child to the doctor if at the very beginning of any complication should they foresee it. Now look at this child. I mean, every person who saw this child said that he's so adorable, such beautiful eyes. But he presented to my friend actually in his clinic because of watery eyes. And luckily for the child and for us, they were able to pick up the diagnosis of congenital glaucoma. Now, obviously, the child has very beautiful and big eyes, but this is an entity known as ophthalmos and or congenital glaucoma. And if you see a child with very large eyes with watering, always think of this entity. Now, another common cause of watering in children is trauma. Now, and I cannot emphasize enough the importance of a complete and in-depth examination of a child who has had even a trivial trauma. Because look at this girl. I mean, the story is very surprising because she was walking with a glass of water in her hand and she fell down the stairs, and the parents say that she had bleeding at the time, but with ice compressions and some paracetamol, everything subsided. So when she presented to the emergency of the next day, they only thought that it was a small laceration of the eyelid, and that was the end of the story. But soon after, she started having watering of the eyes. And then when she presented to me later, we realized that during that episode of trauma, she also had a glass piece which had cut the inner corner of her eyelid, damaging the lower canaliculus, and which of course followed healed by cicatrization and hence led to watering. Now, I mean, that's why I want to emphasize, why this detailed examination is so important, because these small things, had this been picked up at the time of the primary incident, you can really easily recanalize that canaliculus with much more higher success rates than doing this as a secondary procedure after the cicatrization has set in. Now, this is another very, very common things, and especially in children, is foreign bodies. The foreign bodies, as you can see, can be very, very tiny. They can be present on the cornea or anywhere in the eyelid. And, if you see in the first picture labeled B, you see the small black colored foreign body impacted in the tarsal surface, which can be easily missed on a torchlight examination. If you're not really looking for it, it can continue to cause problems to this child for many, many days. The also not just the cornea, but the conjunctiva. Now, if you see the small lesion, the rounded lesion in green, that is an abrasion of the conjunctiva. So not just the cornea, but even an abrasion of the conjunctiva should be looked out for, because it can cause significant problems. And I want to just say this because it is so common to have something go into the eyes. If the next time anybody comes in with this problem, I would encourage everyone to do at least these two steps before deciding what to do next. One is flush the eye with clean water. And when I say flush, we're not meaning 5-10 ml syringes. I personally recommend 1 to 2 liters of water, because it is not uncommon that either a foreign body or a chemical is missed in the eye. It has been scientifically documented that you should be washing the eye with at least 1 liter of water. And especially if there's a risk of chemical substance injuring the eye. So the way we do it in the emergency room is to use an entire liter of ringalactate solution, and with the IV set, just continuously, slowly wash the eye completely. The other thing which must be done is to to avert the upper lid and both examine the undersurface as well as wash it thoroughly. Now, other commoner causes of watering could be just an infection or an inflammation of the eyelids. Of course, on the first side, it is a typical stye or an external hordeolum. And but sometimes there's blepharitis, which is at a very low level and ongoing constantly, and very rarely, sometimes the cause of this is a mite. And if you can see on the right hand side a picture of an eyelash which has been plucked out of a child with a constant blepharitis, and it shows the Demodex follicularum, these 2 mites which were there within the follicle of the eyelash, and they were the cause of the constant blepharitis, which was not being resolved for years actually. Another very unusual presentation and cause, this one patient came with a hydatid cyst in the eye. Of course, it's very rare, but it can happen. So all in all, I would say, I mean, there are many there are many publications to document the causes of watering, and in this, and especially in pediatric age group, and in this particular um, case, this one, we saw that most common cause was congenital nasolacrimal duct obstruction, followed by trauma. So this is, just a glance of what are the different and various causes of watering of the eyes. But I would just like to walk you through what do you do when a child like this walks through the gates of your clinic. As of course, in any case, we wanna think about we want to go systematically and get whatever clues we can get from the history and collaborate them with our clinical examination, and I'm going to concentrate on what you can do in your very own clinic without the need of fancy equipment which are more easily available to ophthalmologists. So you know can we do something about the noise? Okay, I'll go ahead now. So each and every thing can give us a clue towards diagnosis. Now, about the age, as I mentioned earlier as well, that it is not necessary that a congenital issue has to present from birth. It can present later in life. Also, the laterality, is it unilateral or bilateral? Because if it is a systemic problem, then it's more likely to be bilateral, versus something like more like a structural issue is likely to be unilateral. The duration and constancy again will give you a clue towards, is it something acute? Is it something that has happened recently? Like, for example, in trauma, it would be like a few hours or maybe a day. And constancy will tell you how severe or how um, what exactly is causing. Because if it's a constant watering, then either the tears are constantly being produced because of whatever the cause is, or more likely there's an obstruction leading to inadequate drainage, because tears are constantly produced in the eyes any which ways. The other thing which is very, very relevant is the discharge and the type. So if the child has just watery discharge, I mean, if and you must always inquire, like, if the eye is constantly watering, is it just water, or is it mucoid, is it sticky, or is it pus or yellow, and does it have a smell, or because that will give us a clue towards, is it where the obstruction is, and is there presence of any infection or an inflammation. Presence of swelling, and the swelling could be on the eyelids, for example, or in and around the sac area. Again, will point us towards the diagnosis, because it's very typical to have a swelling just under the inner corner of the eye, in patients with nasolacrimal duct obstruction, versus if there's any infection or inflammation in the eye itself, you must expect some amount of eyelid swelling. So if the eyelids are pristine, and there's no swelling, you can be rest assured that there is no inflammation, because the skin and the soft tissue around the eyelids is so thin that they will swell up at if there's any inflammation in the area. And prior treatment is extremely important to find out if the patients had any prior treatment, not only to kind of gauge the diagnosis, but also to prognosticate the outcome of the intervention if anything is planned. Difficulty in breathing is difficulty in breathing is something which must be actively looked out for, especially in neonates
Diwali
with
Farah.
watering of eyes.
Full release. It's not much. Actually, my bhabhi has made most of it. No, मेरा कौन? He has made it. Some of it is from this shop. He will touch it.
Just a request to everybody to please mute themselves.
So, how are you doing? Happy? Why?
I'm sorry, can we be muted from
Doesn't want to go to London.
Okay, I think we'll just go ahead.
But there also it will be difficult only.
Okay, so as I was saying, there's always
thoda. Hi, good evening. He's more than happy, na? So,
I'm sorry, do we have an option of muting everybody from the presenters end?
ये चकली बिकली भी है वो हम लोग क्या करते हैं ना हम लोग फ्राइडे और सैटरडे
Should I go ahead?
No, Diwali. Laddu and karanji and everything. We on Saturday, na? Saturday is the Diwali day, right? So we sit in the morning, we have in the thali, we put everything. It's actually tradition. I don't know.
Dr. Shah, should I go ahead with my presentation?
Homemade. A little bit is from the shop. Most of it is homemade. My cousin's wife. You are taking good care of. No, uncle. You are taking good care of yourself and her also, hai na? Really, she trusted everything, na? No,
sorry, Dr. Sneha, trying to get the host to mute everybody. Give me a minute. So sorry.
Yeah,
that's fine.
You have to give, na? Here also it's a tradition. Full stage. No, but Diwali ko like everybody expects, na? Abhi Gurkha Birkha bhi expect karte hai. Mummy and
Madam, you can mute her.
Yeah, are we okay to go on now?
Yes, please. Thanks.
Hello. Yeah, so I'm going to go ahead now with the clinical examination. Hello, can you see my screen and hear me as well?
Yes. Yes to both. Yeah.
Yes, fantastic. Sorry. All right. Okay, fantastic. So in clinical examination, I think if it is possible, like, to whatever level, we must document what's the level of vision. Even if it is just counting fingers, you don't have to have all the vision charts and all the details, but just make sure, like, is the child able to follow your finger, or if the child is old enough, can count the number of fingers from like a 6 meters, and just document it because it becomes very important and in the follow-up as well. The other thing, and this is my favorite test by far, which is regurgitation of pressure over the lacrimal sac. And the reason why it's my favorite is it has excellent sensitivity and nearly 100% specificity. So it's very easy to perform, and this is a test for nasolacrimal duct obstruction. Now, if you all know, like from anatomy, that the lacrimal sac lies behind the medial canthal tendon in the lacrimal fossa, and the way to approach lacrimal fossa from the surface of the skin on this side is just behind the ridge which you palpate on the corner of your nose, just behind and under the medial canthal tendon. So if you just apply a little pressure in this corner, and there's discharge in which flows into the eye, obviously from the puncta, it kind of confirms nasolacrimal duct obstruction. And going by what kind of discharge is there, will, if it is just mucoid, then you know that there's no active inflammation. But if it is dirty yellow pus-filled discharge coming out, then you know that it is acute dacryocystitis cystitis, and the infection needs to be managed first. Then, of course, please do not miss out on ocular adnexal examination, meaning to say all the structures around the eyes. And, like I said, the skin is the skin allowing adequate closure. Is there any inflammation? As we saw, children with a stye or blepharitis or even ptosis. Lashes, what is the direction of eyelashes? Is there any entropion? Is that causing any irritation to the eye? The margins of the eyelids, are they opposed to the lacrimal, to the ocular surface? Because if there's an ectropion or an entropion, both can cause watering of eyes. And of course, even under torchlight, it is possible to see, at least if there's a punctum, probably not in a very small child like an infant, but in older children, of course, just a flash of torch and averting the eyelid can, at least that there's a presence of punctum, because that is quite common. Examine the conjunctiva, just make sure that it is to check if it's inflamed. Is it red? Is there any foreign body, both in the pharyngitis as well as on the surface itself? Now, look for example, in this child, I'm not sure, but you can readily make out that the level of the tears is much higher than we would expect normally, right? This is something what we have thought ophthalmologists call as a tear meniscus height, that the amount of tear film above the eyelid margin, and it should typically be less than 0.5 of a millimeter. Another very nice and a very, very physiological test, which I see no reason cannot be performed by a general practitioner, is a fluorescein disappearance test. Now, basically, what we're trying to judge is the tract from the eye to the nose patent, right? And the way to very easily do this is to color the tears. And we can do this with something called as a fluorescein dye, which is available as small strips of paper, which are wet with lubricating drops, and one drop is instilled in each eye. I think my next slide has a video on it to demonstrate the. Oh dear. Okay. So I'm sorry, the video is not there, but it's a very simple test wherein you can instill this color in the tears and wait for 2 to 3 minutes, because that's how long it takes for the tears from the eyes to go into the nose and the throat. I think many people are surprised when I tell them that there's a passage from the eyes to the nose. But they understand, because it's very common that you put drops in the eyes and it gives a really bad taste in your throat. So do you ever wonder why that happens? Or do you ever wonder why you're kind of sniffing every time you cry, right? So I tell my patients, it's when you're crying excessively, more water is going into your nose, and which you end up sniffing away. So and that's when they believe me, because most of the time patients are they don't believe that there is a pathway from which the waters drain out. So now once, with the history and the clinical examination, we establish a diagnosis, then it becomes very much straightforward to kind of treat it. Rarely, if none of this gives us any clue, there are more tests which can be done depending on what we are suspecting. So there's something called as a dactyocystography. There's scintigraphy, and we do Schirmer's tests, just to see how much tears are being produced. Is it excessive? Is it less? Um, uh, to your breakup time. And so, of course, if things are getting more complicated, and we do have many more tests in our kitty which will guide us and help us. Of course, a CT scan if we think that there's something more behind. Now, a very short snippet about a few cases and what we do these days for management of congenital nasolacrimal duct obstruction. Has anything changed since over the years? So basically, um, uh, the very first step and most commonly, it's very effective, is conservative management. I would encourage each and every primary physician to know the right method for the Krigler's massage, which is nothing but the massage of the lacrimal sac, which is recommended to children with who are suspected to have congenital duct obstruction, because this can be extremely effective, right? And so this must be, spent that extra 2 to 3 minutes in your clinic explaining and demonstrating to the parents or the caretaker how this massage has to be done, because nearly, like I would say, 70 to 80% of the times when the child comes to us finally, either he's more than a year of age now, and now there needs to, we're thinking about doing an intervention. And I ask, how have you been doing the massage? It's usually on the bone in the corner of the eye. So not only are they, having a placebo kind of a thing, I mean, they're just spending time, massaging the bone of the corner of the eye with no effect. So uh, what you have to do is pressure over the lacrimal sac. So make sure you ask the caretaker to to pare their nails, because the nails can hurt the sensitive skin of the child. And then with either a little Vaseline or something to kind of lubricate the skin in that corner, just a little pressure beyond the ridge. Now, what that's very important. It cannot be in the corner of the eye. They have to feel the ridge of bone and go beyond it, and then put pressure on the sac. So what the idea is that hydrostatic pressure on the sac will open up the thin membranous blockage down the path. And I would really implore people to use antibiotics judiciously. We know that we usually think about intervention at around 7, 8, 9 months of age, and oftentimes I've seen children having put antibiotic drops for months together before they come, because they've just been recommended to do so. Now, the longer they use the antibiotics, the more resistant the bug's going to get. And I would not recommend the constant use of antibiotics in the absence of inflammation. Of course, when there is an acute attack, we would give both oral as well as topical antibiotics, but there is no role of using just topical antibiotics as prophylaxis to prevent an infection. So this is, just an overview of what we actually do during syringing and probing. We examine, so we do it under microscopic guidance, and we examine the entire lacrimal outflow system. These are the simple instruments which are used to kind of open up the plumbing. Some of the contraindications to syringing is, of course, if there is any inflammation, active inflammation. So if there is acute dacryocystitis, that is not the time to intervene unless, of course, it's life-threatening. but that should be subsided with antibiotics, and any intervention should be done at a later point, because any inflamed um, uh, thing will be inflamed tissue is likely to form false passages and scar excessively. Um, so for in the management, we usually intervene at 3 months, at 9 months of age, or if you've done conservative treatment for over 3 months and it hasn't responded, it is fair enough to go ahead and consider an intervention in this child. Um, and we do an early probing in cases of an amniotocele. So as I would discuss in history, you must think about, you must question any infant with watery eyes if there's any difficulty in breathing, because the lacrimal outflow system can bulge into the nasal cavity, forming what is known as a dacryocele or an amniotocele, and it sometimes, and there have been cases where it is bilateral, and that's actually dangerous to the child. And yeah, so what, and this is such a rewarding surgery, because a child comes in like this, and within a week of the procedure, and they go out smiling. So it's a very, very successful procedure if done at the right time and in the right way. And this is just, to show, I mean, there's a lot of numbers there, but just notice that all the studies, if you look at the timeline, they are much, much more successful when done earlier than later, or after 24 months. So don't just sit on, don't say that, let the child grow up and we'll deal with it later, it's just a watery eye. Well, it might just be a watery eye, but it can hamper vision, it can cause repeated infections, it can be significantly distressing, and the outcomes are much, much better when dealt with earlier in life than later. Of course, a lot of children come to us when probing has failed one or multiple times before. And I always check and try to see what exactly was done, because we do syringing and probing always under endoscopic visualization, and we have pediatric endoscopes to visualize the system, and we have special intubation systems which can be placed if we feel that it is a more complex case, or if it is more inflamed at that time. And we do not hesitate to use other investigational modalities such as DCG if we feel, and that's something that has helped us solve a lot of cases with failed probing, to find out where exactly the issue is. The other thing which is in vogue these days is called balloon dacryoplasty, is something again which we are able to do. Of course, DCR is kept as a last resort for patients, children who have not responded to any kind of other treatment, and we reserve it, usually do it after 5 years of age, when the facial growth is approaching 90 to 95%. As you can see, I don't want to get into details, but these are pictures of endoscopic vision under endoscopic guidance. We are looking at the inferior turbinate, and there are a lot of things can go which can be different, and which can go wrong, or which can there can be anatomical variations, and having this in our kitty helps us appropriately manage many, if not all, of these cases. So this is just a DCG, just to show you how well and how fantastically it outlines the complete system, and it helps us plan our intervention in an appropriate way. These are some of the newer tubes which are used. And when we have to, when no other options are left, this is a child who was 9 9 years of age with like a lacrimal abscess, lacrimal sac abscess. We went ahead and we did an endonasal DCR. And within a week, this is what she looks like on the right. There's a small scar, which of course we can deal with much later. But if we were to do an external DCR in a child with an inflamed lacrimal sac, the outcomes would have been disastrous with a significant amount of scarring. So I just want to, kind of run through another case which we recently did, not more than a month ago at SRCC, just to highlight the importance of, being alert and referring at the right time. Now, this was an 11-day-old child who had, just, the usual swelling and redness around one eye. And the pediatrician said, use topical antibiotics and increase the next day, then shift on to oral antibiotics. But they were so good that on the third day, they said, you know what, this is not responding to antibiotics. This is something more. So then they referred to higher centers. And finally, by the time the child reached SRCC, it was on a Saturday evening. We did the CT scan of the child immediately, and there was massive proptosis. There was no eyelid movements. Pupils were non-reactive. Luckily, the cornea was clear. The pediatrician had already advised taping of the eyelid, so the cornea was, not damaged at all. But definitely intraocular pressure was already raised, and it was not looking good. If you can see in the second picture, the eyeball was literally popping out, and more than, I would say, 5 millimeters of proptosis in an infant, right? So immediately we did a CT scan. We saw a multilobulated mass in the left orbit, but because there was some suspicion of a lymphovascular malformation, we went ahead, did a Doppler scan on the same day, did an MRI to confirm the cause of this, and it was actually just a nasolacrimal duct obstruction with a fistulization into the orbit, leading to a lacrimal abscess. Now, such a simple thing like a nasolacrimal duct obstruction and can lead to something so dangerous, where having, if this would have been left alone for another couple of days, I think the child would have lost his eye because of the extreme pressure that so much proptosis puts on the nerve as well as the vasculature of the eye. So very thankfully, it was picked up early and referred appropriately. We did endoscopic visualization and opened up the lower end of the nasolacrimal duct, and immediately we saw pus coming out from there. We went ahead, we removed whatever abscess was accumulated in the orbit, removed all the loculi, and then on the very first day, that's how it completely resolved, and the child is doing fantastically and has recovered both vision as well as function of the eye. So that's just that was one of the most recent cases which I could think of appropriate to this talk, and to kind of the importance of referring at the right time, and because so much of it can be managed at the primary level. I think if you have a good understanding of why things are occurring, a lot of these disasters can be avoided. So that's it from me. Thank you. I'll just stop my screen share now. Give me a moment. So that's it from me, and I'll be happy to answer any questions or anything that anyone would like to ask.
Madam, does
if I could just ask one question, is that is there anyone who hasn't seen or hasn't had a patient with watery eyes? I mean, I think it's such a common entity. I'm sure nearly everyone would have come across this. But has anyone had any, any issues in dealing with such children?
Which are the common antibiotic eye drops we should use?
I think in the pediatric age group, I really prefer tobramycin. So Toba eye drops, which is 0.03%, 3 to 4 times a day is the best.
Not the Ciplox or the Moxiflox.
So I would reserve moxifloxacin if it is repeated recurrent infections not responding to tobramycin. But my first
Choice is
drug of
Toba.
choice would, yes.
And often they complain of tired eyes after working on the computer. Then for soothing, they want something. Is there particularly eye cool drops or something? Any?
Yeah, so lubricants can be quite commonly and easily
Yeah,
prescribed over the counter. They do not have any side effects. But I think we must also emphasize, take that opportunity to emphasize, and educate them about computer vision syndrome, because especially now with more and more children spending more and more time on screens, we must educate them about computer vision syndrome, wherein, constantly looking at a closer surface is going to tire your eyes out. So you must you must be aware that you have to focus away at regular intervals. So I'm sure you know about the 20-20-20 rule, wherein every 20 minutes for 20 seconds you should be focusing at an object more than 20 feet away. So that's something that we must impress upon. Apart from, of course, we can prescribe lubricating eye drops, and I think all of them are safe to be used in children.
Madam, sty does require oral antibiotic.
So I think if it is caught in the very early stages, when it is very small, it hasn't insisted, then just hot fermentations with. So I always encourage people to use eye ointment. The place where the sty is arising is from the eyelid, right? So if you're not achieving anything by using antibiotic eye drops, but you do have antibiotic eye ointments which can be used, and they should be massaged on the eyelid margin. So that's one thing I recommend along with hot fermentations. But this is only in the very early stages when it hasn't become like a like insisted. So once you can see the pus point, at that stage, no topical antibiotics will help, and you will need systemic antibiotics.
Hi, Dr. Sneha. A couple of questions from the chat. One is, what is the treatment of congenital glaucoma?
So that's an extensive topic on its own. We have pediatric ophthalmologists and glaucoma specialists even dealing with that. They're various stages, and depending on when and how much damage, and there are many things to it. So it could be just using topical drops, or usually a surgical intervention is required. Yeah.
Madam,
I think,
treatment of blepharitis in both the eyes.
I'm sorry, I didn't quite get that. Treatment of
blepharitis in both the eyes.
Dacryocystitis or adenitis?
Blepharitis.
Blepharitis. Okay, sorry. So again, blepharitis is something which is very common. You must always think about, is it a posterior blepharitis or an anterior? So blepharitis is nothing but inflammation of the eyelid margin, right? And it could happen because of the anterior layer, which is the eyelash follicles being affected, or the posterior layer where the meibomian glands are affected. And that is the crux of treatment, because if you are treating inflammatory cause with antibiotics, it's not going to help. And at the same time, if you're treating an infected cause with anti-inflammatories, it's not going to help. So things like anterior blepharitis are usually caused by staphylococcus. So I would encourage an antibiotic eye ointment again to be applied. And if it is more like a blepharitis, like a posterior blepharitis, then it is more like hot massages, hot fomentation, eyelid massages, and anti-inflammatory or a mild steroid ointment to be applied. So I think the first thing which has to be established is it where is the blepharitis coming from, and then proceed with the appropriate treatment.
Okay. There was one more question on if you could demonstrate the correct way to do the massage for the nasolacrimal duct obstruction.
I am so glad someone asked this because it's something that's very close to my heart, and like it would really help. So basically, I'll just turn my face around. If whoever asked this question, just place your little finger, your pinky finger, in the corner of your eye, just under the medial canthus, right? So that's the medial canthus. You're placing it just under it, and roll your finger backwards, so you feel a ridge of bone. So you go behind there and just do that, right? So you yourself will feel some pressure because you're applying pressure on the sac. And if that's, and I would recommend like 3 times a day at least, for 2-3 minutes each time. And usually if you sync it up whenever you're feeding the child, the mother is feeding the child, it's not as traumatic. So and one more thing which I missed is, please do not advise massage to a child with acute infection or an inflammation. Just today, I had a call wherein the mother was vigorously massaging the child, and there was bleeding from the eye. Okay, so if there is inflammation, if there is infection, at the moment there is pus coming out of it, don't massage. But when this all settles down, with antibiotics, with whatever, that's when you have to start, and make sure you're massaging with enough and adequate pressure. So I usually tell, if the child is not, crying or resisting, you're not doing it well. So if you're just like kind of doing that, the child is liking the nice massage and going off to sleep, well, you're not doing the right thing.
General rule not to massage whenever there is pain and inflammation.
So the massage can cause pain, but of course, if there's already pain, don't massage. You're quite right.
Exactly.
Madam, does chalazion also causes watering of eyes? Chalazion?
No. So chalazion is when it has already become non-infective. It is not inflammatory, and it is just a collection of the sebum inside the gland, and it usually does not cause any irritation. So as I said, the watering of eyes has to be like an irritant to cause watering. Now chalazion, usually if it is not very massive, usually a chalazion will not cause any irritation and any reflux, hyperlacrimation.
Yeah, removal of foreign body at our level, GP level. Just give some hints.
I would say, as I said, just flush the eye with a lot of, whatever, saline or RL, or, or even clean water. That is the best thing. Of course, you should, you can retract the fornices. We do have anesthetic eye drops which are used, so that will immediately put the patient on, will make the patient relaxed, because a foreign body in the eye, it's like, they say ant in a elephant's trunk. It's very irritating. So the moment you put the anesthetic eye drop, which is trade name is Paracaine. So it's basically a proparacaine eye drop which is available. You numb the surface of the eye and then wash it. Of course, you can use Q-tips. So sterilized Q-tips or cotton buds can be used to remove any foreign body which can be in the fornices. So both the lower as well as the upper. So you can evert the upper lid, observe for any foreign bodies, and if there are any foreign bodies there, they can be removed with with a cotton bud, but I will encourage this to be done only under topical anesthesia. So make sure you've used paracaine drops, and yeah, if
And
it is
what?
on the if it is on the surface of the cornea, um, if it's not going away with flushing with saline or water, don't attempt to remove it without adequate magnification. So we always use a slit lamp, which is nothing but a very very fancy magnifier, but it tells us the depth of the foreign body, because the cornea is 500 microns thin. Okay, so even a small foreign body for the body can be very big for the eye. So think about that, and I wouldn't encourage anyone to remove a foreign body from the cornea, but of course from the fornices, from the corners of the eye, a Q-tip is quite, or a cotton bud is quite useful.
That was extremely useful information, going into the holiday weekend.
Yeah, yeah. And with Diwali coming up, so
Madam, there is sometimes mites are present on the eyelid. How to remove? And is it advisable general practitioner to remove it or refer it?
so I think in my presentation as well, I showed some mites which are present in the eyelids, Demodex follicularum, either brevis or the magnum. uh, they are not always needed to be removed, right? So sometimes they are present as natural flora. So unless they are causing a problem, don't remove it. If they are causing a problem, even it's a nightmare, even as a oculoplastic specialist, to remove them, because we use something called as tea tree oil, which are basically irritants to these mites, and they come out. That is not the problem. The problem is once you apply the tea tree oil and the mites start coming out, that can happen an hour, 2, 3, 4 hours after the child has come to you, and then they can go onto the ocular surface, cause an abrasion, and cause havoc. So I don't treat mites unless it's causing a problem, because they can be a part of the natural flora. If it is causing a problem, I would, I'd imagine that you'd leave that headache to us, because it's quite a headache, really. And you have to be really, really careful while doing that, because tea tree oil itself can be toxic to the eye.
If in a child there is redness of eye with medial conjunctival flictin and watering and scaly eyelids, it's a chronic history. What will you think of? Some kind of an allergy?
So the very fact that there is scaling, I think if the eye is watering and it is red, there is some inflammation, right? And the eyelid component could be just because of the constant watering and excoriation from the skin. So I will be inclined to think about some kind of an inflammation of or an allergy even.
Medial conjunctival flictin, with the flictin and redness of eye.
So flictin is typically tuberculosis, but now we know with experience it can happen even without that. But yeah,
and with redness,
it's common to have. Yeah, it's common to be present with allergic conjunctivitis.
Okay, thank you.
There are sometimes ecchymosis is present on the angular conjunctivitis. Swelling,
Yes.
edema.
Yes.
What to do? Either give oral antihistaminic or locally steroid.
Yes. So if we feel like in viral conjunctivitis, I give once a day dose of a very low potency steroid, such as maybe fluoromethalone or loteprednol. So just once a day to control the inflammation. But it should be antibiotics as the mainstay. But this one drop of a steroid once a day after 24 hours of an antibiotic coverage goes a long way in controlling the inflammation and, as you said, chemosis.
Madam, sometimes only redness of eye, there is no discharge, nothing. The vesicant drops.
So no redness of eye should be treated without finding out the cause. So, if there's just redness, you avert the eyelid, see if there's any papillae. So if there's a papillae, then it's going towards allergy. You have to find out the cause for redness before treating it. So if you're saying it is only allergic conjunctivitis, then you treat it as that. But I wouldn't per se treat just redness of eye without finding out, because even acute iritis, even iritis, like not acute, but iritis can present with only redness of eyes. So yeah.
Thank you very much. Your slides were fantastic.
Dr.
Thank you
Sneha,
so
we
much.
have a couple of more questions. One is, how do you manage a corneal abrasion, when it's happened late in the night and you're waiting to see the doctor the next morning? How can it be managed overnight?
Yeah. So I would put one drop of antibiotic. So I emphasize antibiotic drop and not an ointment, because ointment can be very greasy. So one drop of antibiotic. If it is very painful, one drop of homide, which is a cycloplegic agent. It kind of controls the inflammation inside the eye, and just patch. So make sure that the patch is tight enough that the eyelid is not moving within, but not so tight that it impacts any foreign body if it is present inside. So I would say just wash the eye completely, put a drop of antibiotic. If very painful, put a drop of homide, give oral painkillers like paracetamol, patch the eye, and then the patient can see the next day.
Okay. And how do you manage blepharitis caused by dandruff?
That I
So
wanted
so
to ask.
that yeah, that's very and the moment such a patient comes to you, you must explain to them how it is not easy to treat dandruff, right? You can't explain that you do this 1 week or 10 days or 15 days of treatment and the dandruff will go away. So the dermatologists aren't able to do that. Even we will not able to be completely cured the dandruff, but we can kind of keep it at a much controlled level.
Can the host please mute the other attendees, please?
Sorry, I just lose my train of thought. So, yeah, and so the three things to do is wash the eyes with lukewarm water and maybe a little bit of baby shampoo. Now, the reason why we use baby shampoo is it's not irritant to the eye, right? So just a little bit of baby shampoo, lukewarm water, wash the eyelid margins because the lid margins is where the problem is. A little bit of hot fermentation, because hot fermentation increases the blood supply, and a mild steroid ointment on the lid margins. So, like a trade name is Occupol DX or a Neosporin H eye ointments. Just as much as a rice grain is what I explain. You just need to use so much. Don't use a whole lot, and rub it on the eyelid margins. So twice a day should be good enough initially, and then you can even do just once a day after the bath every time or in the night before going to sleep. And that needs to be done a little, like 6, 8, 10 weeks until it completely subsides. So you can't just do it for 2 weeks, expect it to go away and then stop. So the steroid drops should not be used for more than about 2 months in a go. And if it is being used, then for any term duration longer than say a month, I would say the intraocular pressure needs to be monitored, because some of them can respond, are steroid responders, meaning to say steroids will increase their intraocular pressure. So if you feel that there are certain children who need this constant, you give them a steroid, they subside, and they come back after 3 months. So if they're constantly needing the use of steroids, their intraocular pressure should be monitored.
I had a question. So, with children who have like watering eyes for some time, the parents rush them to an eye doctor and say, oh, it's a refractive error. And I don't know, like I think it's a misconception that refractive errors can cause watery eyes, or is it the first thing that should be looked for?
It is one of the things that should be looked for, definitely, simply because how common refractive error is. Any strain, because children trying to see things clearly, it does put strain on their eyes and it can cause watering. So I wouldn't take it off my list, but it won't be the first thing on my list either. So as I said, look at the history. Is it both eyes or is it just one eye? If it's just one eye watering, I mean, really refractive errors is not what I'm thinking, right? So, yeah.
Okay, I think we have no more questions. Thank you so very much. That was an excellent lecture. Learned a lot. Thank you very, very much for attending, to everybody. And I would also like to announce our next masterclass, which will be on 2nd of December. I'm going to go ahead and announce our speaker, our topics, and we are waiting for confirmation from the speaker. So this is our tentative program. One is Management of Headaches in Children by Dr. Anaita Udvadia Hegde, our senior pediatric neurologist. Management of Constipation in Children by Dr. Rakesh Shah, our senior pediatric surgeon. And Allergic Diseases, a ghost diagnosis by our pediatric pulmonologist, Dr. Varankar. So this will happen on the 2nd of December, 2:30 to 5:30 p.m. So with that, we can end today's session. Thank you so very much to all the speakers. Excellent sessions.
Madam,
And hello, yes,
Happy Diwali to you, all of you. May
yes.
Diwali bring you a
Happy
lot of
Diwali, sir.
joy, happiness, health, wealth, and peace of mind.
Oh, so
Yes,
sorry.
happy wishes for a happy Diwali to everybody, and best wishes for a new year. Thank you.
Thank you so much for the invitation, and it was excellent. Thank you for the lovely audience. Happy Diwali.
Thank you. Happy Diwali.